Bismillah ar-Rahman ar-Rahim. Welcome to the second session of today. It's a pleasure to introduce Dr. Imad Rakha, professor and consultant pathologist, School of Medicine, University of Nottingham, senior consultant, Hamad Medical Corporation, Qatar.
السلام عليكم. يعني we have 20 minutes. I will try to yes. Lisa? Okay. I will try to have a comprehensive overview of the molecular pathology in breast cancer. As we know, breast cancer is a very heterogeneous disease with different tumor types. If you look at WHO book, we have like 25 histological types and the variants, 3 grades, different stages, morphology, different behavior, different treatment. So it's a bit of heterogeneous disease.
الصوت مش واضح.
الصوت مش واضح؟ كده واضح؟ اوكي ماشي. So we need, morphologically is a bit very heterogeneous disease. So sometimes we need help to reach to a final diagnosis and to refine the classification. So we need molecular pathology to first understand the biology of this heterogeneous disease, refine the diagnostic classification, and improve the risk stratification. So how to stratify patient according to risk and according to response to treatment. And at the same time, molecular pathology will help us identify novel targets or therapeutic targets. So if we think about understanding the biology, breast cancer is different from like other carcinoma like lung and kidney and the urothelial carcinoma. It is characterized by gene expression alteration, more than a mutation of a gene. Even if you look at ER and HER2, it is gene expression, is not mutation. So only very few genes are playing important role in breast cancer, like BRCA1, BRCA2, germline. And if you look at the somatic mutation, very few genes, ESR1 mutation in a specific situation, and PIK3CA mutation. So it is mainly alteration of expression. And why do you think about, we already know that ER and BR is there in breast carcinoma, but for many years we don't have any new novel targets. What is the reason for this? If you look at lung, now a list of cases. Melanoma, a list of genes. Why in breast is not, we don't have a list of new genes coming up? Because HER2 and the ER are the main player of breast carcinoma and already discovered. And it was the first one in cancer, companion diagnostic in cancer. So that's why most of the coming genes are used in a specific situation, advanced and metastatic setting. So we don't use them in the routine practice. So no need for identifying new targets now at the level of mutation and then specific genes, because we already have ER and HER2, which are the dominant ones. So first of all, as a pathologist, we need molecular pathology for diagnosis. But do you know what is what techniques you should, or what situation should we use molecular pathology? I will list them. First, rare tumor types. Some tumor types are very difficult for us, very challenging, like secretory carcinoma and mucoepidermoid carcinoma and adenoid cystic carcinoma in the breast. We can make a diagnosis of is it malignant or not. Sometimes struggle even secretory carcinoma specifically. Most of the cases secretory carcinoma in second opinion practice, what is this? You don't know is it carcinoma or not. Just a very bland looking epithelial proliferation lacking myoepithelial cells. So for these situations, translocation, if you do FISH, it will confirm the diagnosis. So these are the 3 examples of cases that FISH test or the demonstration of translocation can make a diagnosis. The second one, when we have mesenchymal looking lesion, low grade and high grade spindle cell lesion. Sometimes not sometimes, most of the times, very difficult for us to make a distinction. If you, metaplastic breast carcinoma, it can mimic the FSP. So in this case, if I think about the FSB, you can have a translocation. Metaplastic breast carcinoma versus synovial sarcoma, because synovial sarcoma can express cytokeratin. So it will be in the differential diagnosis of metaplastic breast carcinoma. X18 translocation. Sometimes between malignant phylloides and myxoid liposarcoma or round cell liposarcoma. If it is malignant phylloides, treatment is surgical excision. If it is liposarcoma, they give neoadjuvant therapy. So it's very important to differentiate. In this case, if you confirm a translocation, it is liposarcoma, they will treat as sarcoma. If it is absent, they will treat as part of phylloides tumor. When we have low-grade spindle cell lesion, you don't know scar tissue. We don't, is it a scar or something else? So we use immunohistochemistry, definitely immunohistochemistry, but there are some molecular as well in addition to immunohistochemistry. Myofibroblastoma, you have deletion of certain chromosomes, 13q and 16q. Fibromatosis, if beta-catenin immunohistochemistry is not very helpful, you can do mutation of beta-catenin gene. Inflammatory myofibroblastic tumor, very rare, I saw only one case. But ALK gene mutation or rearrangement is specific for IMT. Nodular fasciitis, one of the differential. Is it a scar or nodular fasciitis? So USP6 translocation or fusion genes. Sometimes in angiosarcoma, is it primary or radiation induced? So c-MYC mutation can differentiate between primary angiosarcoma and to confirm it is angiosarcoma. If you have low-grade bland-looking vascular proliferation, and this patient received radiotherapy due to previous carcinoma or previous wide local excision, and you are not sure, c-MYC immunohistochemistry or mutation can show that this is angiosarcoma or not. So in atypical vascular lesion, it will be negative. If c-MYC is positive immunohistochemistry or positive mutation, it will confirm the diagnosis of angiosarcoma. You know that the entity called the tall cell carcinoma with reverse polarity, which is again one of the very challenging lesion, rare but challenging, and it is invasive carcinoma, characterized by IDH2 mutation. And adenomyoepithelioma, HRAS mutation. So if you have access to PCR and you have a lesion that you cannot make a diagnosis on H&E, you can send it for mutation testing. We know fibroepithelial lesion, fibroadenoma or phylloides, the mid-12 and the third gene mutation. Even now, if you have carcinoma involving skin, is this primary cutaneous squamous cell carcinoma or metaplastic carcinoma of the breast? This is very rare situation, but it's very challenging because the treatment is different and there is no immunohistochemistry can differentiate. So now we are using NGS to differentiate between cutaneous with ultraviolet signature, radiation signature, opposite metaplastic breast carcinoma, it will not show the ultraviolet induced mutation or signature. So it can be helpful in this case of differential diagnosis between the two entities. All of us like prognostic classification, how to classify breast carcinoma based on biomarker. So we can use single genes, we can use multiple genes together like ER, single genes ER, BR, HER2, and so on. Multiple genes, you can use ER, BR, HER2, and Ki67. So you have 5 genes together, used together, you can classify breast carcinoma. Or we can use global gene expression profiling. So look at the thousands of genes and analyze them together. And something in research, not in clinical practice, mutational signature. So you can classify breast carcinoma based on mutational signature. When we look at gene expression profiling, they have 2 approaches or 3 approaches. One is when you classify breast carcinoma unselected, and then you get distinct groups based only on gene expression profiling. This is called intrinsic subtypes, molecular classification, intrinsic subtypes. Different from the term that we use in pathology when we say luminal. This is biomarker defined subtype. When you use ER, BR, HER2, and or Ki67, you call it luminal A, luminal B. This is biomarker defined subtype. But when you use gene expression, it's called intrinsic subtype. So it is the same terminology, but this is biomarker defined because it's not the same. And the other one is gene expression profiling, which is intrinsic subtype. The other one, when you use from global gene expression, they identified a set of genes, like 20 genes, 70 genes, 50 genes, and it's called this, and then correlated this set of genes correlated with outcome. And then they identify a specific set of genes associated with poor prognosis and another set of genes associated with good prognosis, or one single set of genes that can stratify the patient. This is called prognostic signature. Prognostic signature, like what we hear about oncotype DX, mama print, and so on. This is called the prognostic gene signature. The molecular classification, as we know, it is we already know luminal A, luminal B, HER2 positive, triple negative, or basal-like, and the basal-like now can be classified into 7 molecular classes. Is not important for us as a pathologist. We don't use this in routine practice. We use biomarker-defined subtype. Unless if you have access to BAM50 or any molecular technique, you can use it. But we use biomarker-defined subtype. If they looked at the intrinsic subtype, it's a good association with the outcome. But don't forget that if you classify breast carcinoma using the 4 genes, ERBR, HER2, Ki67, you will get exactly the same survival curve. So it is both of them can give you prognostic stratification. And these are examples of studies that compared between the intrinsic subtypes and the biomarker-defined subtypes. And you will face a difference between the definition in different studies. Some of them used the Ki67, some of them didn't use Ki67, some used different cutoff, some used BR. In the past, they used to use HER2. Now, most of the classification system don't use HER2 in luminal. So if it is HER2 positive, it is HER2 positive. It's not luminal B, it's HER2 positive. If it is HER2 negative, it is either luminal A or luminal B, if it is ER positive. And then you classify luminal A and the luminal B. And look at the correlation. This is a correlation between biomarker-defined subtypes and intrinsic subtypes. It's not the same. So the correlation is like 70% of the cases will be the same class, or 30% will be different class. But it is the best available. Not exact, but best available. And important because, for example, look at this one. This is ER negative, HER2 positive. So majority of the tumors are enriched with the signature of HER2. So HER2 is the driver. So those patients will respond very well to anti-HER2 therapy. That's why when you have 3 plus for HER2, 3 plus expression, the response rate about 70%. When you have 2 plus gene amplified, the response rate about 20%. So because the majority of HER2 3 plus and when it is ER negative are already HER2 gene enriched signature. While when you have HER2 positive, ER positive, you split some tumors will be driven by ER and some tumors will be driven by HER2. That's why you have this class of tumor driven by HER2, and these are likely to respond. But the rest will be driven by ER. That's why the response will drop, because the ER-driven tumor will not respond to anti-HER2. Okay? The multi-gene signature is mainly used, like Oncotype DX and others, mainly used in the luminal subtype. There are some description and some mentioned yesterday about HER2-DX, but according to existing guidelines, we use this signature in the luminal subtype, ER positive, HER2 negative. We don't use gene signature in the triple negative or HER2 positive. Not used until now. There are some publication, but not a guidelines, not in routine practice. So, but the problem with this one is not one single. Each group of authors looked at 500 genes or 2,000 genes, identified a set, and then they see that this is a stratifier, because if you it is by chance, random. So if you look at any set of genes, you can classify breast cancer. That's why you have 21, 70, 76, 50, 12, 5, 2, and so on, and different composition. But it is good because it is used in a group of patients that we are not able to stratify based on morphology. So these genes can help you in indeterminate group. You are not sure using the conventional method, so you can use additional method, not to replace. So these are not to replace the existing, not to be against, but to be used in the areas that we are not sure what is this. If you look at this one, Oncotype DX about $4,000, MammaPrint 4,000, Prosigna 2,000, EndoPredict 2,000. This is you have to send it to America. This you can have it in your lab. So if you are, for example, in Bahia, you can buy one of these, either Prosigna or EndoPredict, do it locally if the oncologists are interested in some patient. So this is the cheapest one. Most expensive one are Oncotype DX and the MammaPrint. They are not better than us. If you look at the performance against each other, it is similar to our performance in grade. So when we grade breast cancer among ourselves, we have kappa value of 0.5. And their kappa value is 0.4, 0.44, and 0.5. So the performance of each of the, if you have one tumor and send it to 5 signature, you will get high risk, low risk, high risk, low risk. Kappa value will be 0.5. Similar to our performance when we grade breast cancer. But unfortunately, oncologists and the clinician, they always blame us for having a low concordance and believe in this technology because they use only one. And when you use only one, you get one results. You don't compare. But be careful, because if this is against the, for example, 3 lymph node positive and they see low risk, I will think about it. Is it really low risk, or this test is low risk? If I use a different test, it may be high risk. So the concordance is not absolute. What about predict is a new, you may hear it in research and publication and sometimes coming in practice, predicted biomarker. But I cannot discuss breast without ER. But just the update for ER is 10%. CAP, ASCO, CAP guidelines is 1% initially. But 1% showed that 1 to 10% is not responding very well. 50% of those tumors are already ER negative. So they updated the guidelines and mentioned that if it is 1 to 9%, to call it low positive. And most of the oncologists treat as ER negative. So use the cutoff of positivity as 10%. This is the likely to respond to hormone therapy. Less than 10%, it is up to 1%, you call it low positive, and the response will be similar to ER negative. ER positive, HER2 positive is different from ER positive, HER2 negative, as we mentioned. And remember, ER negative, BR positive, usually a false group. So if in your lab, if you have one case of ER negative, BR positive, pay attention. Do you have false negative ER? Do you have false positive ER? Or is it a true case? The true cases less than 1%. So if you have 500 per year, expect 5 cases only, not more than 5. But if you start getting more and more, your ER is less, you may have a false negative ER, especially weak, you call it negative, or you have a false positive ER. So this is a good quality for us. You audit your case. By the way, you need to audit. We have to audit our practice every year for ER, for BR, for grade. We don't have to have 60% or 70% of our cases grade 2. It means that your fixation is poor. How do you know that the fixation is poor? By having more grade 2 tumor. Because when you have a poor fixation, you don't have mitosis, so you score your cases as 331. So you have majority of your cases will be grade 2. But if you have a good fixation, you identify mitosis, and then the percentage of grade 3 will be about 30 to 40% of the case. At least 40% of your breast cancer cohort in your lab should be grade 3. HER2, as I mentioned, second most important driver of breast carcinoma, and it is described after like 10 years or 20 years after ER. And HER2 3 plus is very important to recognize. It's different from 2 plus amplified. As we mentioned, 3 plus 70% response rate, 2 plus amplified about 20% response rate. So it is, and currently you will hear about HER2 low and HER2 ultra low, and the story of may not come to Egypt because the drug is very expensive. So I'm not sure which patient will be, but at least oncologist will attend some of the meeting, will come to you, ask you, pathologist, can you assess ER low, ultra low, super ultra low? They will start asking these. You have to prepare yourself and know how to respond to them. So there is nothing called what is low, ultra low is the same scoring, same immunohistochemistry that you use, but just the category score 1, you just need to pay attention more. Is it 1 or not? And the story of ultra low is when you see if it is completely negative, it is 0. If there is any membranous staining, you call it ultra low. But this, as I mentioned, still it is just the only situation when oncologists ask you, can you do low, ultra low? You say, yes, we can. Because we already score 1 plus, we already score 1 plus and 0 already. It is just will be attention. We can review the scoring to make sure that did we score it accurately or not. And second, ultra low is between 1 and 0 when you have few cells with positive membranous stain. So it's not a challenging, it's very easy, but it's challenging for them for treatment, not a challenging for us. Something new, which is ESR1 mutation. when the patient develop recurrence after aromatase inhibitor once and twice, they can send the patient for ESR1 mutation. Currently, they do it in liquid biopsy, but some places they do it on fixed material. So ESR1 mutation is coming to the, because the treatment is tablet and is very effective, elastistran. So the oncologist will ask you for ESR1 mutation. See that we don't have liquid biopsy, but we can do it on the tissue. The second one is called the PIK3CA mutation, which is alpelisib is one of the target for this. If you have mutation, the patient will be eligible for this. This is a highly toxic drug, not used frequently, but still some oncologists will be interested in this. Only 1 minute left. You may have heard about immune checkpoint inhibitor, BDL1. This is we use only the marker, which is 22C3. The other one is SB45 obsolete now. We are not using because it is only pembrolizumab. They started with atezolizumab, but it is withdrawn. So we use BDL1, only one colon, which is 22C3. We assess it for pembrolizumab in triple negative only, not on all breast cancer. Okay, SB45 is already obsolete, not used. Atezolizumab is not used at the moment. And the PARP inhibitor, we know it is used in germline mutation of BRCA1, BRCA2, and I just skipped this one. There are some CDK4/6 inhibitor. We don't need to worry about it because it's based on ER positive, HER2 negative. No companion diagnostic. It's called the CDK4/6 inhibitor. Palbociclib and ribociclib and abibaciclib. So it is if you call the case ER positive, HER2 negative, no need to worry about CDK4/6 inhibitor. And antibody drug conjugate, maybe we'll discuss it in other talk. What is the antibody drug conjugate, which is used like what we mentioned, TDXD and HER2 low and HER2 ultra low. And this is because of the importance of antibody drug conjugate and HER2 low. The UK guidelines was updated now to split HER2 into HER2 positive, HER2 low, and HER2 negative. So this is the updated guidelines. I think I exceeded my time now. Should I stop here? Because 20 minutes passed. Yes.
It's open for discussion.
Any questions?
شكرا يا دكتور عماد على التوك الهايله، ميرسي قوي. كنت عايزه اسال حضرتك بالنسبه للتيبل اللي هو المقارنه بين الانترنسيك سبتايب طلع قد ايه زي الاميونوز، هل ده اخذ في الاعتبار مثلا في الاي ار السكورينج؟ يعني حضرتك قلت في 70% concordance والباقي كان نون concordance كانترنسيك سبتايب.
اللي هو المالتي جين سيجنتشر، الديفرنس بين المالتي جين سيجنتشر
بالظبط.
the discordance is higher than what we expect.
Yes.
So it is similar to.
طب هل مثلا الديسكوردنس ده هل كان له علاقه مثلا بالسكورينج ولا ما حطوش في الاعتبار؟
لا، اصل هم
these
are different gene sets. So oncotype DX, for example, the 16 genes are mainly proliferation. The others, some of them are related to immune signature, other signature. That's why some of them will recognize the tumor as high risk, some will recognize. Already within oncotype DX, already, ER, if we don't have oncotype DX, to be honest, you can stratify the patient exactly. Because if you write the percentage of ER, and the intensity of ER, and the percentage and the intensity of BR, and the Ki67, this is enough. If you combine them together, you will get a stratification equivalent to oncotype DX. If you wanted to add more, you can add the size and the grade of the tumor, size and the grade. With those four, we compared the performance with exactly the same between oncotype DX and adequately assess the grade, adequately assess the size, and adequately assess the ER, BR, and the Ki67. So it is, we can perform, but the problem is the oncologist, they believe in technology, as a test. This is, but that's the importance of us adequately assessing these variables.
Yes.
So this is our job, our responsibility.
Thank you very much.
Welcome.
One more question, Dr. Ahmed.
Thank you, Professor Ahmed. Do you think that comprehensive genomic profiling will outdate those scoring systems? I mean, with comprehensive genomic profiling invading our decision making actually right now. And previously we thought breast cancer were only 5 types with the luminal. Now there are 18 types with the CGP. So do you think with the implementation more of comprehensive genomic profiling, we will not use those gene signatures and scoring systems?
The problem was there's a difference between science and reality. The problem was, for example, oncotype DX is validated in clinical trials in a specific situation. So oncologists will use it even if you show that the intrinsic subtypes, if you accurately assess them, they will perform better than oncotype DX, but still use oncotype because of the validation and the approval. So they will not replace now until this will be proven in other clinical trials. But to be honest, any approach you take, you can stratify your patient. So if you use BAM50 on its own, you can stratify the patient. If you use, what is the added value of 18 types? What is the added value of 5? You know, it is. Yeah, but there is currently no link between what you are saying and the specific medication. This is the problem, because how do you know that if it is one class would respond to this specific treatment? Each question of this will need other clinical trials. This is the problem. Is this a science? Okay, we believe in it, but can you apply to your patient? What is your evidence? This is the problem. You can see prognostic but it's not predictive.
Yeah. What I mean, for example, you mentioned the ultra low, the Destiny
Yes.
06 was
Yeah, but
announced,
this is a
for
clinical
example.
trial.
I know, but قصدي that this is the future, the upcoming future.
Yes,
because
yes.
Before we didn't know that we could approach
Yes.
those patients أصلا.
Yeah, definitely.
Okay, thank you.
Thank you very much.
Now I have the pleasure to introduce the second talk entitled Metaplastic Carcinoma, Low Grade or High Grade, for our promising pathologist, Dr. Hazem Abdelaziz.
Good afternoon. I would like to thank all of the attendees for being here, and I would like to thank our valued chairperson. I would like to thank my mentor, Dr. Nair Anwar, and my professor, Dr. Huda Ismail, for being here. And I think we are the extension of them, and everything may be good. That's why that's their implant in us, and I hope my lecture today adding something new for the attendees. And I am very happy to have you here today, and I'm looking forward to seeing you every time in Bahia conference and workshop, and we are promising to introduce to you all the new in the breast pathology science. Today we are this session is about challenging in management of breast cancer. When I think what to introduce for this year, it came to my mind to discuss metaplastic carcinoma, because metaplastic carcinoma, when it comes to our field, first it's exciting. Once we hear metaplastic carcinoma, every one of us has his own thoughts. So I decided to explore with you the magnitude and the challenging of the metaplastic carcinoma. At first, I would like to define the word of metaplasia. The word meta is derived from the Greek word meta, which means beyond or transcending. Beyond, as we say, metaphysics علم الماورائيات، يعني ما وراء الطبيعة. فكلمة meta, it's what's behind. Okay. The name origin of metaplasia in the Greek verb metaplesian, which means a change in form. It's transformation from one differentiated cell type to another differentiated cell type. That's why we call it a change of form or metaplasia. Okay. When we say metaplastic carcinoma, pathologists get in their mind and get ready to have a heavy meal of findings, a heavy meal of challenges in diagnosis, and a heavy meal maybe of immunostaining and other things. Our colleagues in MDT decision teams Our surgeon, it's exciting for them to treat with metaplastic carcinoma for sure, as they expect aggressive tumor, a larger tumor, maybe ulcerating tumor, because it always presented by late stages. While our colleagues in medical oncology field, that's their status. دايما بيتعاملوا مع الميتابلاستيك carcinoma as a catastrophic because it has the very pessimistic and very black prognosis. Let's start about clinical facts about metaplastic carcinoma. The incidence, thanks God, metaplastic carcinoma has the least incidence of carcinomas. Less than 1% of breast cancer are diagnosed as metaplastic carcinoma. About the age, it's similar to other types of invasive breast carcinoma with no predilection for specific age group. Presentation typically presented as a large palpable mass may be associated with rapid growth or even ulceration. Prognosis, limited prognostic data are available due to rarity of metaplastic carcinoma and infrequent case series published on the literature. We have a good news for surgeons that axillary lymph nodes metastases are less common in metaplastic carcinoma compared to other cancers of similar size. Yani if we have two tumors of the same size, this type is metaplastic carcinoma and the other is invasive duct carcinoma or liberal carcinoma or what so else, I expect that metaplastic carcinoma may be less having axillary lymph node metastasis. Nodal metastasis is very uncommon for tumors showing spindle cell and squamous features, including other types of fibromatosis-like and low-grade adenosquamous carcinoma. We have a good news for surgeons, but we have bad news for medical oncologists, as metastatic route may be primarily hematogenous to lung, brain, and liver. So first metastasis may be of distant metastasis. Prognosis for some types of metaplastic breast carcinoma is significantly worse than non-metaplastic breast carcinoma in some studies, including the triple-negative breast cancer. It may be related to a higher stage at presentation. So we can tell that metaplastic carcinoma is a heterogeneous group of tumors that have only one thing in common and a lot of things to be uncommon. The common thing is the tumor cell transformed from a benign mammary cell, epithelial or myoepithelial, to a cell type with malignant properties such as squamous cell, chondroid cells, and other type of mesenchymal cells. These tumors have more differences than similarities, including morphology, biology, and more importantly, the prognosis and therefore the management. That's why the metaplastic carcinoma is very challenging in diagnosis and management. Okay, let's go closer for the classification of WHO for metaplastic carcinoma, as metaplastic carcinoma is not one entity. WHO mentioned 5 types of metaplastic carcinoma, naming them as squamous cell carcinoma, spindle cell carcinoma, metaplastic carcinoma with heterologous mesenchymal differentiation, fibromatosis-like metaplastic carcinoma, and finally low-grade adenosquamous carcinoma. Let's start by metaplastic squamous cell carcinoma. It represents 10% of all metaplastic carcinomas, not all breast carcinomas. It is at 10% from the metaplastic carcinoma. It's often located centrally in the breast, which is an important, very important clinical and radiological findings to differentiate the squamous cell carcinoma of the metaplastic carcinoma type and from the cutaneous squamous cell carcinoma. So it's I may need this information in specific and maybe the only exit to have a diagnosis of metaplastic breast carcinoma of squamous cell type, not a primary cutaneous squamous cell carcinoma. It may rise in areas of squamous metaplasia secondary to inflammation. Cells that undergo metaplasia may be myoepithelial cells. Cell of origin may be myoepithelial. It changed into squamous cell, then it changed to a malignant form. Another clue for diagnosis, which make me comfort to diagnose squamous cell carcinoma of metaplastic type, is presence of squamous cell carcinoma in situ, which may present in a cyst wall or a duct. Squamous component of metaplastic breast carcinoma can range from well differentiated with good keratinization to poorly differentiated. دكتوره ناديه مختار، على رايك دكتوره ناديه دايما بتقول لنا let's go to the colorful world of the pathology. الصوره اللي على اليمين هنا دي عندنا السكويمس سيلز، nest of squamous cells showing moderate differentiation surrounded by dense inflammatory cells, tumor infiltrating lymphocytes, and here a clue for diagnosis of metaplastic breast carcinoma of squamous cell type. I can see here the DCIS. Okay, this is a clue for me that is a primary metaplastic squamous cell carcinoma of breast origin. Another entity which may be deceiving and may be mimicking for another type of malignant tumors is the squamous cell carcinoma of acantholytic pseudoangiomatous pattern. In this type, there is marked acantholytic changes that may mimicking angiosarcoma. So cytokeratin is important for every case. I may diagnose as angiosarcoma. Do cytokeratin, even if you are sure that this case is angiosarcoma. Do cytokeratin and do CD34 or ERG to assure your diagnosis. The other type is spindle cell carcinoma. To differentiate this tumor from the less aggressive tumor, another tumor called fibromatosis like metaplastic carcinoma, this tumor have intermediate to highly atypical cells. I should have in my slides highly atypical nuclei and breast mitotic activity. The other differential diagnosis is a primary or metastatic sarcoma to the breast. Sarcomas primary or metastatic is treated differently from squamous cell carcinoma, making the distinction clinically essential. So I have to do all my best to reach the diagnosis. Is it a sarcoma from outside the breast, or it's a sarcoma arising in the setting of metaplastic carcinoma? Again, presence of DCIS, epithelioid cells, and the expression of one epithelial markers favors the diagnosis of spindle cell metaplastic carcinoma. Also, B63 has a very important role. About 19%, 90% of spindle cell sarcomas can express B63. This is our photos for spindle cell sarcomas. We can notice here the spindle cells. Hena spindle cells also. This is a clue. This is a metaplastic carcinoma, not a primary sarcoma or metastatic sarcoma. I can see nests of residual epithelial nests. Here too, I can see squamoid cells and nests, and here some ducts within a spindle cell background, pure background with myxoid changes. And this is the B63 staining. Okay, so B63 may be adding a value for accurate diagnosis. Here I can see ductal carcinoma in situ surrounded by metaplastic spindle cells. Third type is metaplastic carcinoma with heterologous mesenchymal differentiation. This is a mixed epithelial and mesenchymal variant of metaplastic carcinoma with chondroid or osseous differentiation. Essentially, the hallmark of the diagnosis is having a chondroid or osseous, rhabdoid or neurologic differentiation. Once I see these types of mesenchymal differentiation, come to my mind to diagnose metaplastic carcinoma with heterologous mesenchymal differentiation, which we are calling it matrix producing in our practice as a pathologist, matrix producing metaplastic carcinomas. These components could have either an abrupt transition or very focal intervening zones of spindle cell metaplasia. So in these types of metaplastic carcinoma, it's not essential to see spindle cell component. I can see only the matrix and the epithelial component. Some cases showed very focal intervening zones of spindle cell metaplasia. The diagnosis has to be confirmed by positive staining also for epithelial markers. Here is photos of or images of matrix producing carcinoma. We can appreciate here the mesochondroid background. Here is the osseous background. Here is again megazochondroid background with abrupt transition from epithelial to chondroid matrix without any intervening spindle cells. Here is an abrupt transition from epithelial to the chondroid element without a spindle cell also. Here I can see carcinomatous element and squamous cell element. Both are side by side and have no spindle cell in between. So this is are the five impacts of metaplastic carcinoma with five types of WHO classification. But in this type in specific اللي هو قلنا عليه اللي هو metaplastic carcinoma with heterologous mesenchymal differentiation, some cases showed pure mesenchymal component. I can't find any epithelial component. This will add a more challenging finding for me. I can't find the epithelial component that make me sure that I'm dealing with carcinoma. So I can mistake in these cases as another type of primary, such as extraskeletal osteosarcoma or chondrosarcoma or rhabdomyosarcoma. The only way of making the diagnosis is positive staining also for epithelial markers favoring carcinoma, but in some cases I can't find any epithelial components, so the diagnosis might be not possible, especially in the biopsy basis. So I have the right in some cases of biopsies that are not representing epithelial component to name it as malignant spindle cell for excision, and trough cut sections within the excised specimen is the way to find what I'm searching for of epithelial component. There is also unusual clinical and pathological presentation of metaplastic carcinoma arising within complex sclerosing lesion. Complex sclerosing lesion may arise, may have a small component of metaplastic carcinoma. So every case of complex sclerosing lesion, I have to search thoroughly to exclude the presence of metaplastic carcinoma component, especially of the type of low-grade adenosquamous carcinoma. Largest series of this special subtype showed 33 cases reported by Gobi and his colleagues. This entity is very important to recognize as it can easily be overlooked and misdiagnosed and lost in diagnosis when evaluating complex sclerosing lesions. This is photos for a complex sclerosing lesion with part of spindle cells. Some of these spindle cells show atypical mitotic figures, and this one is surrounding a part of infarcted papilloma. When we have a mixed component, the designated diagnosis is mixed metaplastic carcinoma. Also, we have a fibromatosis like metaplastic carcinoma, which is showing a very low and very bland looking fibroblastic proliferation, mimicking the fibromatosis, and the diagnosis also can be confirmed by positivity for cytokeratin, and beta-catenin is not essential to be positive. The other type of low-grade adenosquamous carcinoma is also may be detected. It shows two components. The one component is like low-grade squamous cell carcinoma, and the other component is showing a glandular differentiation. There is also desmoplastic stroma entangling lymphoid aggregates, which may be clue for diagnosis. So when I have more than one type in the same tumor, I call it mixed metaplastic carcinoma. This, as shown in this picture, here is a lobular carcinoma component and associated with matrix producing metaplastic carcinoma. Here I can see squamous cell carcinoma component with keratin with adjacent matrix producing metaplastic carcinoma. literature بتقول ان لو انا لقيت اكتر من 3 انواع it's more associated with worst prognosis. لو لقيت 3 انواع من carcinomas in the same tumor, this carry a poor prognosis. الهرمونال status for metaplastic breast carcinoma 90% are negative for ER and PR and HER2. And still now we are treating it like it's like triple negative breast cancer. Rare cases showed the positive reaction for HER2 enriched, and they have a better prognosis than triple negative metaplastic carcinoma. Metaplastic carcinoma and therapy response, only 10 to 15% have pathologic complete response compared to 30% or more for similar cases of triple negative breast cancer. Metaplastic breast carcinoma is most common type of triple negative breast cancer to progress during treatment. So if I have a triple negative breast cancer case that is progressing during treatment, I can suppose that this tumor may show metaplastic carcinoma on excision. Metaplastic breast carcinoma may be more resistant to chemotherapy than other types of breast carcinoma, which has a genetic predisposition and genetic composition that leads to this chemo resistance. A molecular background of metaplastic breast carcinoma and the potential target therapy. As we said, it's a heterologous tumor, and we have to find alternative therapeutic solutions to treat such aggressive tumors. So these target therapies may be based on the molecular background of metaplastic breast carcinoma. انا هحاول الوقت عدى فانا هحاول امشي سريعا. most mutations هنتكلم على الميوتيشن بتاع الميتابلاستيك بريست كارسينوما. البي 53 is the most common mutation up to 60 to 70%. البي 13K or البيك 3 CA showed are seen in 30 to 60% compared to only 8% in triple negative breast cancer. The Wnt pathway is more common in metaplastic breast carcinoma, 50% compared to triple negative breast cancer, which is only 28. Third promoters is seen in 25 to 47%, more common in spindle cell carcinoma and squamous cell carcinoma. Copy number alteration, there is gain of 1P or 5P chromosomes or loss of 3Q are the most common copy number alteration. Gene amplification, I can found EGFR, especially in cases of squamous cell carcinoma, and MEK amplification. Metaplastic breast carcinoma and the BRCA mutation, some cases showed BRCA mutation, and it's important to mention this finding. Adding some treatment for these cases showed a benefit for treatment. Cases of metastatic metaplastic carcinoma with osseous differentiation and the BRCA mutation showed marked response to liposomal doxorubicin, is a member of anthracycline anti-cancer drug group. So metaplastic carcinoma can have a distinctive molecular signature, but as Dr. Ahmad Raha said, it's of the group of triple negative, so the gene signature is not used till now. Gene expression, it shows expression of cadherin repressors, so cadherin is lost in metaplastic carcinomas. It shows claudine-like and stem-like patterns of gene expression, and showed chemo-resistance protein expression, which is the cause of chemo resistance. BDL1 and metaplastic carcinoma as triple negative breast cancer. BDL1 may play a crucial role for treatment of metastatic cases of metaplastic carcinoma. This is how expression. I can see strong expression in cases especially of squamous cell carcinoma, negative expression in chondroid, which is the least, moderate expression in spindle cell, and here again the chondroid matrix showed negative expression of BDL1. So can we classify metaplastic carcinoma into low grade and high grade? By morphology, I can stratify metaplastic carcinoma as low grade and high grade. High grade include spindle cell metaplastic carcinoma with heterologous mesenchymal differentiation, and squamous cell carcinoma high grade. While low grade features are seen in fibromatosis like metaplastic carcinoma, low grade adenosquamous carcinoma. Next, we can put here the entity we said rare entity metaplastic carcinoma arising within complex sclerosing lesion, and finally the squamous cell carcinoma showing well differentiated morphology. This is by morphology, but it's better to not to say low grade or high grade. I think we have to say low risk or high risk, as low risk tumors may be more informative and this entity is including low-grade adenosquamous carcinoma and fibromatosis like metaplastic carcinoma and spindle cell carcinoma associated with complex sclerosing lesion, while high-risk tumors included the spindle cell and squamous cell metaplastic carcinoma and matrix producing carcinomas with sarcomatous element. Dr. Ahmad Raha has his publication in this aspect 2015 saying that the spindle cell has the worst prognosis among all these cases, including that one showing matrix production. Spindle cell metaplastic carcinoma has the worst prognosis. واحنا مصدقين دكتور عماد. تمام. Take home message: high risk metaplastic carcinomas has worse clinical outcome than triple negative breast cancer. Combining various histologic subtypes under one entity designated as metaplastic carcinoma is misleading. We are not dealing with one entity. We are not treating a single type of carcinoma. It's heterologous types of carcinoma. So don't take the word metaplastic carcinoma by itself. Go behind, go meta, be meta as the tumor is meta. Go meta and know what is the underlying subtype of metaplastic carcinoma. Some of the subtypes have the worst clinical outcome. They are the high risk groups, and other has indolent clinical behavior. They are the low risk. Spindle cell carcinoma associated with complex sclerosing lesion could be challenged to diagnosis, and the pathologist should be aware of this entity to avoid missing an important diagnosis. Proper histomorphology interpretation and wise choice of immunohistochemistry could assist in rendering correct diagnosis of spindle cell lesion of the breast and avoid improper diagnosis. Target therapy and immunotherapy are promising ways to combat high-risk metaplastic breast carcinoma of various molecular alteration, and up-to-date target therapy and immunotherapy is undergoing clinical trials. Thank you.
Thank you, Dr. Hazem, for this informative talk. And now we move to the other.
It's my pleasure to introduce Dr. Osama Abdelmohaimin. He's my colleague, lecturer of Medical Oncology, National Cancer Institute, and consultant of Medical Oncology in Bahia. He's going to give us the third talk today, and it's going to be exploring role of PARP inhibitors in breast cancer.
Thank you for introduction. My topic today about expanding the role of PARP inhibitor in breast cancer, starting with mechanism of action of PARP inhibitor. PARP inhibitor leading to cell death through trapping of PARP1 into DNA. Leading to DNA damage and cell death, and by the concept of synthetic lethality, PARP inhibitor blocks the cell ability to repair single-stranded DNA breaks, which convert to double-stranded DNA breaks, keeping the cell unable to repair and causing DNA damage and cell death. Starting with the role of PARP inhibitor in metastatic breast cancer, and firstly, when to test BRCA1/2 mutation in metastatic breast cancer, including patient factors less than 45 years of age at diagnosis of breast cancer, or less than 60 at diagnosis of triple-negative breast cancer, diagnosis of bilateral breast cancer, or history of ovarian cancer at any age, or first or second degree relative, or personal history of male-breast cancer. Other factors, including family history, is a first-degree relative diagnosed with breast cancer less than 50 years of age, or more than or equal first or second-degree relative diagnosed with breast cancer, any male relative diagnosed with breast cancer, or more than or equal one grandparent of Ashkenazi Jewish heritage. First trial is Olympiad trial, was a phase 3 trial investigating olaparib monotherapy versus chemotherapy in patients with HER2-negative metastatic breast cancer, including patients with triple-negative breast cancer or hormone-positive HER2-negative breast cancer with germline BRCA mutation, with a study design Patients were randomized to olaparib 300 milligram versus chemotherapy of physician choice, including capecitabine, eribulin, or vinorelbine. Primary endpoint was progression-free survival, and secondary endpoint was time to second progression, overall survival, and objective response rate with a follow-up of about 14.5 months. Regarding patient characteristic, half of patients were ER/BR positive and the other half were triple-negative breast cancer. Median progression-free survival for olaparib arm was 7 months versus 4.2 months for chemotherapy with hazard ratio of 0.58. Median overall survival for olaparib arm was 19.3 months compared to 17.1 months for chemotherapy with a hazard ratio of 0.9. Also, Olympiad trial was not powered to show an overall survival benefit. Overall survival benefit also appeared to be the greatest in patients receiving treatment in the first line setting in the olaparib arm, with a median overall survival of 22.6 months versus 14.7 months for chemotherapy, with hazard ratio of 0.51. Regarding response, overall response for olaparib was 60% versus 29% for chemotherapy. Main adverse event for olaparib was nausea, vomiting, and anemia versus nausea, vomiting, and neutropenia for chemotherapy. Second trial was BRCA trial, a phase 3 trial comparing talazoparib as an oral PARP inhibitor versus chemotherapy of physician choice in patients of advanced breast and metastatic with germline BRCA mutation, including triple-negative breast cancer and HER2-negative hormone-positive breast cancer, with a study design patient randomized to talazoparib 1 milligram versus chemotherapy of physician choice, including capecitabine, eribulin, gemcitabine, or vinorelbine. Primary endpoint was progression-free survival, and secondary endpoint was overall survival and duration of response. Median progression-free survival for talazoparib was 8.6 months versus 5.6 months for chemotherapy, with a hazard ratio of 0.58. 1 year progression-free survival for talazoparib was 37 versus 20% for chemotherapy. Regarding duration of response, median duration of response was 5.4 months versus 3.1 for chemotherapy. 1 year sustained response for talazoparib was 23% versus 0% for chemotherapy. Based on these two trials, NCCN guidelines recommending olaparib and talazoparib as a first-line treatment in BRCA mutation in patients with triple-negative breast cancer and even in HER2-negative hormone-positive breast cancer with BRCA mutation. Coming to the role of PARP inhibitor in early breast cancer, and starting with Olympia trial, which answers the question of if we treat subclinical micrometastasis in early BRCA mutant breast cancer, can we do better and improve survival or not? Study design including neoadjuvant group of triple-negative breast cancer with non-BCR or hormone receptor positive with non-BCR with CBS EG score more than or equal 3, and adjuvant group including triple-negative breast cancer with more than or equal T2 or more than or equal pathological N1 disease, and hormone receptor positive with more than or equal 4 positive lymph node. Patient randomized to olaparib 300 milligram versus placebo for 1 year, with a primary endpoint invasive disease-free survival and secondary endpoints including distant disease-free survival and overall survival. This is the CBS EG scoring for breast cancer, including clinical stage, pathological stage, ER states, and nuclear grade. 3 years, invasive disease-free survival for olaparib arm was 85.9% versus 77.1% for placebo, with a hazard ratio of 0.58, while 5 years invasive disease survival for olaparib was 82.7% versus 75 for placebo. Coming to distance disease-free survival, median distance free survival was 86.5% for olaparib versus 79.1 for placebo, with a hazard ratio of 0.61. Regarding overall survival, 4-year overall survival rate for olaparib was 89.8% versus 86.4%, with a narrow survival benefit for olaparib versus placebo and hazard ratio of 0.69. Main adverse event for olaparib was nausea, fatigue, and anemia. Based on Olympia trial NCCN guidelines recommending adjuvant olaparib in hormone-positive HER2-negative breast cancer with BRCA1/2 mutation with CBS-EG score more than 7 in patient receiving neoadjuvant treatment, and also in triple-negative breast cancer with germline BRCA1/2 mutation with patient with more than T2N1 disease. Coming to combination strategy in early breast cancer, which including many overlapping indication between PARP inhibitors and endocrine therapy, chemotherapy, immunotherapy, and others. Firstly, biological rationale, why there is a combination strategy in early breast cancer, including to overcome resistance to PARP inhibitor and other systemic treatment, and synergistic effect between PARP inhibitor and chemotherapy by accumulation of DNA damage, and by immunotherapy through higher tumor neoantigen load in the tumor. PARP inhibitor approved in combination with endocrine therapy in high-risk BRCA mutant breast cancer, but many overlapping indications are now challenging between olaparib and pembrolizumab in triple-negative breast cancer with BRCA mutation in patients receiving neoadjuvant chemoimmunotherapy, or olaparib and capecitabine in triple-negative breast cancer with BRCA mutant with residual invasive disease. Also olaparib and abemaciclib in early high-risk breast cancer with node-positive, hormone-positive disease. Regarding safety profile, combination with olaparib and pembrolizumab of that which can be given together safely, yes, while limited data regarding the combination between olaparib and capecitabine in the adjuvant setting, or olaparib and abemaciclib in high-risk hormone-positive breast cancer. In Olympia trial, olaparib initiated already up to 12 weeks after local treatment in the adjuvant setting, and Olympia trial also capecitabine not taken in residual invasive disease in triple-negative breast cancer. If there's any potential role of PARP inhibitor in neoadjuvant setting, many ongoing trials comparing PARP inhibitors with other chemotherapy and immunotherapy in the neoadjuvant setting of it. This pattern trial of that investigating paclitaxel carboplatin versus paclitaxel carboplatin with olaparib, with the primary endpoint safety and pathological CR, and secondary endpoint including relapse-free survival, distance-free survival, and local recurrence-free survival. Another trial investigating combination between PARP inhibitor and immunotherapy in early stage BRCA mutant triple-negative breast cancer, and asking the question, can a chemotherapy-free neoadjuvant treatment strategy be optimal in a patient with BRCA mutant or not? Our take-home message today is that germline BRCA1/2 mutation is an important systemic therapy defining biomarker in early breast cancer and metastatic breast cancer. PARP inhibitor is approved as a monotherapy or even combined in endocrine therapy. Adjuvant olaparib improving invasive disease-free survival, distant disease-free survival and overall survival in BRCA mutant early breast cancer with hazard ratio of 0.6, 0.63, 0.61, 0.68 respectively. Capecitabine safely in combination, not safe in combination with olaparib is inadequately tested and is still unproven to be taken together. There is many overlapping indication of olaparib in the adjuvant setting, and there is a potential role of PARP inhibitor in neoadjuvant setting. Thank you very much.
Thanks a lot, Dr. Osama, for this comprehensive speech and on time, but we are going to postpone the discussion to the end. Moving to the next speaker.
Thanks, Professor Osama. Now I have the honor to introduce my dear friend, Professor Muhammad Awad, and he will talk to us about early lobular breast cancer, confronting challenges and unlocking opportunities. I think we will have an amazing 20 minutes with Professor Muhammad Awad. He's a great presenter, and we will be happy with the upcoming presentation. Please, Professor Muhammad.
Thanks, Dr. Hussam, for your nice and elegant introduction. Dear professors and colleagues, my distinct pleasure and great honor to join you again in Bahia Cancer Center Congress. Allow me to thank Professor Dr. Amani who invited me to this wonderful event. الحقيقة يعني أنا اتبسطت أكتر كل سنة الكونجرس moving forward كل سنة أحسن. كنت لسه بقول للدكتور اماني هو بقى بالنسبه لنا كاونكولوجيست بقى العيد السنوي بتاع الانكولوجيست، كلنا بنستنى البهيه كانسر سنتر كونجرس، وانا فعلا مبسوط ان هو امبروفنج. انا شايفه كل سنه لو جينا نشوف معدل النمو، الحاجه الوحيده اللي معدل النمو بتاعها عالي في مصر اعتقد هو الكونجرس بتاعكم. So please keep on. You are doing a very great job. So my task is to convince you that early lobular breast cancer should be treated as a separate disease. Regarding pathology, regarding radiology, medical oncology, and surgery. Who will agree with me? Is it a separate disease? So the chairpersons agreed with me, so my mission has been done. Okay. Thank you. بس الدكتورة هبة مش موافقة. Not working. So this will be my agenda for over the upcoming 20 minutes. First, I will address the challenges in the diagnosis of lobular breast cancer. In fact, invasive lobular breast cancer accounts for 10 to 15% of all breast cancer cases, making this cancer the sixth most common cancer in women. So it is a very common cancer, more common than some of GI malignancies, all urinary malignancies, more common than brain tumor, more common than hematological malignancy. So it is a common cancer entity. It has a unique molecular and biological profile due to the lack of CDH1 expression in a significant number of cases. CDH1 is encoding E-cadherin, which is not only an important adhesion molecule that is lost in lobular carcinoma, it also carries very important survival and proliferation signals needed for the tumor to proliferate and survive. So the tumor is dependent on other growth factor signals rather than the CDH1 E-cadherin B-catenin pathway. So the tumor also has unique clinical features, more commonly diagnosed at older age, postmenopausal for sure, higher rate of multicentricity, contralateral in 14% of cases, and in almost 1/3 of cases, it fails to form lump, more advanced stage at diagnosis, mostly low grade, and with a unique metastatic behavior. It tends to recur later than IDC, more than 10 years, and also have unusual metastatic sites. For example, it can go to the leptomeninges, the serosal sacs, can go to the GI, can go to genitourinary system. Regarding the risk factors, we have some differences. CDH mutation is 10 times more common in invasive lobular carcinoma, and BRCA1 mutations are almost exclusive for invasive duct carcinoma. It has a distinctive pathologic growth pattern of infiltrating cores of disc cohesive cells, but unfortunately for the pathologist, between expert pathologists, the concordance is only 65%. So, from the molecular knowledge to the clinic, we have to test by immunohistochemistry for the E-cadherin. A loss of E-cadherin is characteristic for the lobular breast cancer, and for sure it will aid the pathologist to standardize the diagnosis. In fact, lobular breast cancer has variants. The typical variant, which is almost 90% of the cases, is hormone receptor positive, HER2 negative, and low grade. We have also a typical variant, which is present in almost 11% of the cases. It is ER negative or positive and HER2 positive. Sometimes it is triple negative, and more commonly grade 3 tumor. We have a special variant, which is the polymorphic variant that looks to be more aggressive. It has many diagnostic challenges for the radiologist. Clinically, it fails to form a palpable lump. For mammography, it is less often a mass, 4 times more often as architecture distortion, and on ultrasound, it is often isoechoic. And looking at the lady, she came for screening, and she was lucky. The radiologist picked up a tiny speculated lesion. Looking at the same lesion on MRI, you can find some heterogeneous shadows of enhancement surrounding a definite mass with some diffuse speculations. This is from the same patient. So MRI can let us see what is not visible. It can change the clinical decision in 50% of cases. And due to the poor concordance between sonomammogram and the pathology, MRI has now been recommended by the guidelines to be included in the initial evaluation of invasive lobular carcinoma. If the patient is unfit for MRI, he has a pacemaker, he is afraid of closed spaces, and so on, we have a novel entity which is contrast-enhanced mammography. It is simply a mammography plus the contrast. And as you see here, we have a patient with a lesion that is ill-defined with mammography, but on contrast-enhanced mammography, we have a well-demarcated lesion by the contrast. It looks to work similar to MRI, but probably less effective in staging the axilla. For staging for distant metastases, actually invasive lobular carcinoma, like other ER-positive tumors, might be hypometabolic. And we have a case here with MRI. She presents with a heterogeneous breast lesion on MRI scan. As you see, a heterogeneous and multifocal breast lesion on MRI scan. On PET-CT scan, she is free of tumor. It is hypometabolic. And if you find this picture, be sure that if the patient is metastatic, it will not be evident on PET-CT. The same patient engaged in a trial for gallium FABI-PET, which is a novel PET tracer. The classic PET-CT is negative, but the gallium FABI-PET shows 2 lesions, one in the breast and the other in the left lobe of the liver. For the local treatment, I don't know if we have surgeons here, but I believe it is a dilemma. Traditionally, for lobular carcinoma, being multicentric, higher recurrence, more lymph node involvement, traditionally the standard of care was mastectomy. But after 2014, when the new criteria for margin positivity, that is no ink, has been applied, the rate of positive margin after conservative breast surgery dropped from 43% to 26%. And the rate of second surgeries dropped from 55% to 20%, and completion mastectomy dropped to 5%. But still the figures are high. So breast conserving surgery is possible with a positive margin rate of 26%. Second surgery will be needed in 20% of your patients, and mastectomy will be needed in 5% of your patients. So you have to discuss with your patient that the option is valid, it's okay, guideline based, but he must be aware that he might go for the surgeon again. She has to be aware for sure. Regarding the long-term safety, we have a retrospective series that has been published in 2011 by Fodor et al. This study included 235 patients with early invasive lobular breast cancer. 163 underwent mastectomy and 72 underwent breast conserving surgery, but this is the only evidence we have. And after 15 years of follow-up, there is a numerically higher rate of local recurrence, 84% versus 77%, but not statistically significant, of borderline significance. But the distant metastasis-free survival and the breast cancer-specific survival was not statistically or numerically different. Now the next question, how safe is sentinel lymph node biopsy in invasive lobular carcinoma? Actually, the Z11 criteria did not exclude invasive lobular carcinoma from their study. However, the number of patients was small, only 24.9%. And we all know that nodal involvement is frequently underdiagnosed clinically in invasive lobular carcinoma, and there is higher likelihood of 4 or more positive lymph nodes. So the Memorial Sloan Kettering Cancer Center has real-world data about the impact of sentinel lymph node dissection in lobular histology. They included 813 consecutive patients of stage T1 or T2 N0 clinically with positive sentinel lymph nodes after surgery and underwent breast conserving surgery. 104 patients were invasive lobular carcinoma. In this series, lobular histology was independent predictor of additional positive lymph nodes with a risk ratio 3.3. But after 42 months of median follow-up, there has been no isolated axillary recurrences, and the authors concluded that lobular histology does not predict the need for axillary dissection. Now we move to our part of my talk, the systemic treatment options in patients with lobular breast cancer. The best scenario to study the efficacy of chemotherapy in breast cancer is the neoadjuvant setting for sure. We can measure the efficacy both clinically, radiologically, and pathologically as well. And as you see here, compared to invasive ductal carcinoma, invasive lobular carcinoma achieves the pathologic CR in only 6.2% of the patients. In patients who are true lobular ER positive, HER2 negative, low grade, the pathologic CR is only 4%. In patients who are grade 3, the pathologic CR is only 7%. And in patients who are ER negative and grade 3, the pathologic CR is only 17%. So chemotherapy might not seem to be efficient in invasive lobular carcinoma, and this has been confirmed in another series. For sure, the atypical variant is more aggressive, but in this series, the pathologic CR rate in typical invasive lobular carcinoma was 0%, and in the atypical form, it was only 15%. Regarding the role of adjuvant chemotherapy in invasive lobular carcinoma, we have the R-Exponder trial that randomized patients who are ER positive or BR positive, HER2 negative with 1 to 3 lymph node plus recurrence score of low or intermediate recurrence score from 0 to 25 to either chemotherapy followed by endocrine therapy or endocrine therapy alone. And looking here at the forest plot, for lobular histology, there is no difference in premenopausal patients from the addition of chemotherapy. Chemotherapy didn't work in patients with low or intermediate risk recurrence score. But in the high risk recurrence score, more than 25, that's 26 or more, definitely there was a benefit. In node positive patients, the benefit was a small, absolute benefit 1.7%. But in patients who are lymph node positive, there was a definite benefit with an absolute benefit in invasive ductal carcinoma 13% and absolute benefit in invasive lobular carcinoma of 12%. So if the patient is having a high recurrence score, there is a definite benefit from chemo in invasive lobular carcinoma, particularly in node-positive patients. Regarding the endocrine therapy, the monotherapy tamoxifen versus letrozole, and the dotted line in yellow here represents the invasive lobular carcinoma. It seems that tamoxifen is not working in invasive lobular carcinoma. The magnitude of benefit from EI was mainly in the lobular subgroup of patients. Also in the SOFT trial, the breast cancer free interval was significantly better with the addition of ovarian function suppression to tamoxifen versus tamoxifen, especially in invasive lobular carcinoma. Absolute benefit more than that gained by Herceptin in HER2-positive disease, 6.8% for invasive lobular carcinoma and 3% in invasive ductal carcinoma. The benefit was even greatest in patients receiving exemestane plus ovarian function suppression, absolute, not a relative benefit of 14%. For combined data of SOFT and TEX trial of ovarian function suppression plus either exemestane or tamoxifen, there was a similar benefit in invasive lobular and invasive ductal. However, the hazard ratio for invasive lobular carcinoma was significantly better. There was a risk reduction of 14% in invasive lobular versus 13% in invasive ductal carcinoma. Regarding the efficacy of CDK4/6 inhibitors, only the PALOMA-2 reported the subgroup of patients with invasive lobular carcinoma, and we have a risk reduction of 54% in this subtype. So CDKs are working well together with endocrine therapy. Now, the novel endocrine therapy avenues driven by the unique biology of invasive lobular carcinoma. We know that invasive lobular carcinoma has many growth factor signals and signaling pathways, including the FOXA1 mutations, and these mutations are probably driving the resistance to tamoxifen. We have also mutations in the CDH due to CDH deficiency, and as I mentioned shortly before, that CDH deficient cells lack important growth factors and important survival signals driven by the CDH. So there is extreme dependent on ROS1 signaling. So adding ROS1 inhibitors to patients with CDH1 mutation will produce another form of lethality, synthetic lethality there. And we have two ongoing trials, the Rosaline trial of adding ROS1 inhibitor in patients with CDH1 mutation to endocrine therapy, and the ROLO trial in the metastatic setting of adding crizotinib, and we are expecting the publication soon, and I believe it will be positive trials. We have also activity of the BTNBI3 key AKT pathway, and now ongoing trials are exploring the efficacy of pan-AKT inhibitor capivasertib in the neoadjuvant and adjuvant setting. So finally, my key insights. The first question, should invasive lobular carcinoma be diagnosed and staged similarly to other breast cancer subtypes? Integration of morphology and immunohistochemistry for ECADHERIN is mandatory to improve standardization of diagnosis and pathologic recognition. Regarding the local staging, we have to offer our patient a contrast-enhanced breast imaging, MRI, or contrast-enhanced mammography. For distant staging, probably PET will not perform well, and we are awaiting validation of novel PET tracers. The next question, should we strictly follow IDC surgical protocols for ILC? For example, do all patients need mastectomy? For sure not. Is breast conserving surgery safe? Yes, we can go, but more frequent re-excision is needed. Is sentinel lymph node safe? Yes, it's consensus-based, we can go for it, but further evidence is required, and there is a risk of more positive lymph nodes. The next question, should we reevaluate the necessity for chemotherapy in patients with invasive lobular carcinoma? The answer is for sure, but subsets of patients like atypical ILC might gain some benefit from chemotherapy. Also, high risk score more than 25 predicting benefit from chemotherapy absolute 1.7 for N0 and 12.2 in N1 disease, but in patients with high tumor stage and typical ILC, the benefit of chemotherapy is still a matter of debate. For endocrine therapy, it is the cornerstone of care for sure. There is a definite advantage of AI over tamoxifen with a risk reduction of almost 60%. There is a greater magnitude of benefit from ovarian function suppression with absolute benefit of 6.8%, and especially exemestane plus ovarian function suppression. Targeted therapies of the PI3K pathway may expand the treatment option in invasive lobular carcinoma. يعني علشان ما حدش يسألني, I have a question for you after finishing my talk. We have a premenopausal patient, classic lobular breast cancer. She is ER positive, moderate ER positive, strong BR positive, HER2 negative. She is lymph node positive. She is resectable, but downsizing is required for breast conserving surgery. So, will you vote for neoadjuvant chemo? Neoadjuvant ovarian function suppression plus AI, but she is premenopausal? Upfront surgery, convince her and convince the surgeon for upfront surgery, or according to other biomarkers, grade and KI and so on. الدكتورة هبة اختارت ايه؟ الدكتورة هبة.
اولا طبعا شكرا دكتور محمد عوض، يعني very nice presentation، ويوجوالي يعني انا فخورة بيك جدا، يعني you are my colleague and my student.
تلميذ حضرتك يا فندم طبعا.
So اللوبيلر محيرة دايما، واللوبيلر is a gray zone، واللوبيلر هي بتاخد اكتر مساحة في الام دي تي for discussion. هنسى اللوبيلر وهقول ان هي ليومينال، وهقول ان هي بوزيتيف ليمف نود، مش هحب اعمل جراحه اكسكلودد، هحب ادي النيو ادجوفنت اللي بيها يا ريت ما تبقاش بوزيتيف. حاجه مهمه جدا عايزه اقولها كل مره، الختم بيتحط والتيكت بيتحط على الكراسه بوزيتيف ليمف نود كارينج ابات بروجنوزيس ات تايم اوف دايجنوزيس، فيا ريت ما نعملش الجراحه وهي بوزيتيف ليمف نود، ده جنرال. فهنا انا ماي ايم ان انا يعني حتى مش بس بريسك كونزرفيشن تبقى نود نيجاتيف. طيب انا اي جو فور اندوكراينال تريتمنت، انا اي بيج فان فور اندوكراينال تريتمنت، بس هنا لازم اكون حريصه جدا، يعني ادي مثلا شهرين واعمل another enhanced mammography واشوف لو ما فيش ريسبونس I can use chemotherapy، لانه the only tool I have now. ما اقدرش اكسلريت بسي دي كي 46 انهبيتور، مش ستاندر وما عنديش. ولكن يعني لو سمحتوا لي، يعني دي حاجه مهمه جدا في الحته دي. دلوقتي ريسنتلي الدكتور محمد بيتكلم على الانفيزيف لوبيولار، الاسم كله كان بيتكلم على الفيليومينال على الانفيزيف لوبيولار. الانفيزيف لوبيولار هي الاريا اللي هيعملوا فيها الدايناميك ريسبونس، اللي هم لو يعني في حاجه اسمها ادابت ترايلز. ادابت ترايلز دي معتمده الجيرمان بيبول معتمدين على اني مش هدي ستريت فورورد نيو ادفانت، I will give a window, a test window. في الغالب هنا هتبقى اندوكراينال تريتمنت، ودو انذر بايوبسي. البايوبسي دي هشوف في السطر الرابع اللي حضرتك حطيته اللي هو الجريد اند كي اي. لو انا في الاتجاه السليم يبقى الكي اي لازم تقل اتليست 30% من البدايه، حتى لو كانت 10 او 15، والجريد تتحرك شويه طبعا باي كلينيكال ريسبونس. يبقى انا هبتدي اندوكراينال وهكونتينيو if I have some dynamic response، لكن if I haven't I will go chemo.
شكرا دكتوره هبه. رغم ان الحاله بريمنوبوزال بس دكتوره هبه فوتد فور اندوكراين ثيرابي. دكتور احمد كان عايز يقول حاجه والدكتوره اماني كانت عايزه تقول حاجه، بس الدكتور احمد كان حابب يتكلم. دكتور احمد كنت عايز تقول حاجه؟ موافق بس تمام. دكتوره اماني كانت عايزه تقول حاجه.
مش عارفه هي بريمنوبوزال وليمف نود بوزيتيف، هبقى شويه قلقانه.
وتيبيكال ليومينال وتيبيكال لوبيولر.
وتيبيكال لوبيولر انا هبقى برضو، بالرغم ان في البي سي ار قليل جدا، وبرغم ان احنا عارفين ان الكيموثيرابي از نوت، يعني اللوبيولر از نوت ذات سنسيتيف تو دي، بس العينه دي لو عملت العمليه وكانت ليمف نود بوزيتيف شي ويل ريسيف كيموثيرابي، لان احنا قلنا ان العيانين ليمف نود بوزيتيف دي ار بينفيتنج. صحيح انا ما عنديش اونكوتايب جي اكس، فانا غصب عني اي عينه ليمف نود بوزيتيف اي ويل جو فور كيموثيرابي. فانا الحقيقه حيرانه ما بين ان احنا ندي هرمونال ولا كيموثيرابي، بس I think I will start with chemotherapy. داون ستيج ليمف نود بوزيتيف، وبعد كده في عندها الاوبورتيونيتي بتاعت الهرمونال بوست اب.
شكرا دكتور اماني. دكتور حسام كان عايز يضيف حاجه اعتقد. حاضر بس تمام. اتفضل.
دكتور محمد فعلا اميزنج ليكتشر. انا متفق معاك ومع الساده الزملاء في الحته بتاعه الميديكال انكولوجي. الاول في حته الراديولوجي انت قتلتها بحثا، واحنا عارفين الجولد ستاندرد باثولوجي، اوكي؟ انما انت بتعمل بيت سي تي وبتعمل ام ار اي وبتعمل النيو بيت سي تي، واي؟
لا
وهل الاي اي هيحل المشكله ديت؟ artificial intelligence ممكن يحل القصه دي؟
لا، هو الاي اي مش هيحلها فور شور في الراديولوجي. هو فور شور الام ار اي ستاندرد خلاص. ام ار اي ستاندرد في ليبل، مفيش جراحه في ليبلر من غير ام ار اي، لان it will change the decision in 50% of patients. يا اما هلاقي مال سنتريك ديزيز، ممكن الاقي كونترالاترال ديزيز، ممكن الاقي ليمف نود. فام ار اي ستاندرد اوف كير. لا انا مش بقول البيت سي تي از مانداتوري، انا بقول if we are staging our patient with bit CT we might be missing the distant meds. bit CT will not perform well in this disease, لكن is not part of the initial workup for early stage lobular for sure.
MRI
for sure.
طيب سؤال دكتوره هبه برضه لحضرتك ودكتوره هبه. احنا في الام دي تي بتاعت التجمع يوم الاربع يعني بنخش نتخانق، مش بنتخانق طبعا، دكتوره هبه هي اللي الابر هاند يعني في البوست مينوبوزال فيميل، اوكي، ليومينال، اوكي، with lymph node positive but more than 3, and if you have your recurrent score it is low score. Did you go for hormonal treatment and did you have evidence for this or not? Thank you.
لا مور ذان 3 مفيش حل يا دكتور ايمن. مور ذان 3 مفيش حل، يعني ملهاش حل مور ذان 3. ده ماي اوبينيون يعني. بس لو الدكتور هبه والدكتور اماني حابين يقولوا حاجه او التشير بيرسون يعني. حضرتك كنت عايز تقول حاجه يا فندم؟
هو في حد
في
لا معلش انا سالت السؤال يا محمد، انا كنت مع دكتور هدى، انا اسف. الاجابه بس كيمو.
الاجابه كيمو طبعا.
كيمو
طبعا.
more than
3 chemo.
Do we have ongoing trial for more than 3 lymph nodes?
I have what?
We have ongoing trial for
yes,
lymph
we don't
node.
have trials for omitting chemo in more than 3 lymph nodes. We don't have data for this.
دكتورة هبة, do you have any study or ongoing trials for more than 4 lymph nodes for hormonal treatment post-menopausal?
No.
يعني you usually consider node negative. بس in many sub-analysis of many trials يعني like ATTACK trial which is very old of 15 days or 15 years, it's happened and we can allow endocrinal treatment from 1 to 3 lymph node, but 4 lymph node is definitely in many trial it's chemotherapy. هو طبعا الدسكشن لا تنتهي يعني. احنا ممكن مثلا نقول كلنا انا خلاص هنزل عن رأيي وهنتبع الاستاذه الدكتوره اماني عشان هي رئيسه المؤتمر. طب if not you have، بص بقى، ما هي الدسكشن هتجيب دسكشن. طب if after 3 cycles of chemotherapy وبنشوفها كتير تاني you didn't attend any 25% response، مش هقول لك partial response كمان، يعني you monitor the response either by your hand or either by radiology، ما بنعملش biopsy. ف if not shall we shift to another aggressive chemo ولا shall we down to endocrine treatment again عشان هي AR positive PR positive.
Thank you
شكرا دكتورة هبة.
Dr.
شكرا
محمد عوض for his excellent presentation as usual. And thanks for the organizer of this successful and interesting conference as usual, and especially Dr. Amani Hilal. And we have the pleasure to introduce Dr. Omnia Orani, Assistant Lecturer of Medical Oncology, National Cancer Institute, and her topic is Impact of Adjuvant Hormonal Therapy on Sexual and Global Quality of Life in Younger Egyptian Female Patient with Breast Cancer.
Good evening, dear professors and colleagues. It's my great pleasure to be here in Bahia Congress of Breast Cancer for the 3rd year, and thanks to Professor Dr. Amani for her kind invitation and support. My name is Omnia Mohammed Orani, an assistant lecturer of medical oncology at National Cancer Institute. And today I will discuss with you the impact of adjuvant hormonal therapy on sexual and global quality of life in young Egyptian women with breast cancer. Our agenda will include an introduction and review of literature, definition of the young age, risk factors for breast cancer in young age, treatment algorithm specific for adjuvant hormonal treatment, and finally, our Egyptian population data. As an introduction, as we all know, breast cancer is the most common malignancy in young women. And breast cancer in young women is of biological and spatial characteristics. And there is series data-based analysis for 243,000 patients. Almost 15,000 of them was younger than 40 years old. If you reviewed with me those clinico-pathological risk factors, almost all the patients below 40s had the bad prognostic clinico-pathological factors. Tumor size more than 2 centimeters, positive lymph node, ER negativity, BR negativity, and grade 3 disease. Not only the clinico-pathological data, which is unique for breast cancer in young age, but also it's a package. There is also associated with psychosocial distress, changes in the body image, sexual dysfunction, treatment-related amenorrhea. The patient go to the menopause early with ovarian premature failure. Also the weight gain and hair loss, which is of special interest, especially in the young women. All this make it very hard for the patient and her physician and should be discussed thoroughly and managed with the systemic non-chemotherapy, radiotherapy, and surgery, in keeping in mind our culture and religious background. Okay, let me ask about the definition of the young age. What is the cut value for the young age? How can we define it? Below 30, below 40, or what is the cut value? Do you recommend?
Below 40.
Range? Dr. Hassam saying it's a range. Dr. Heba, what is the age we can define as young age? Below 40, okay. That is what was adopted by the ESMO and the ESO guidelines. Below age of 40 is a young age for breast cancer. And again, those diagrams showing that it came with, here is the 30 age, and at the end is 80, again for this chart. And below age is combined with higher stage, higher grade, less hormone positivity, and more, of course, triple negativity. The risk factors are the usual for breast cancer, but we should highlight in this patient group the history of childhood chest irradiation and the genetics, the highly penetrance of the genetic mutation, BRCA1 and BRCA2, and the RAD15 and ATM mutation. Okay, if we are considering all these facts, we can agree that the breast cancer management in young age is very complicated and multifaceted. The usual systemic chemotherapy, endocrine therapy, and the local treatment, either surgery or radiotherapy, not the standard for the old age, by the way. In the surgery, we have the contralateral mastectomy, refractive mastectomy, maybe ovarian bilateral salpingo-oophorectomy if the patient is BRCA mutant. So there is special concern for the young age in those 3 big items of management of breast cancer case, but also we had to focus on the rest of this diagram, the psychosocial aspect, sexual health, and the concern about body image, and the fertility preservation, which is recently highlighted in the ESMO guidelines that all young women, irrespective to her stage of the breast cancer, should be informed about the fertility preservation. ودي كانت المفاجأة بالنسبة لي الصراحة ان هو even stage 4 انا هكلمها عن fertility preservation. اللوجيك كان بيقول لا، بس الجايدلاينز قالت ان we should. ومع الايرا بتاعت الامبروفمنت في السيستميك تريتمنت السي دي كي والاي دي سيز والاميونوثيرابي، I think ان البيشنت outcome even with stage 4 is improving. So we should discuss with all the young age patients the fertility issues. Okay, is age per se is a bad prognostic factor? This year database analysis again with 271,000 women, 14,000 of them was below 40 age, showed that the age carries a bad prognosis for breast cancer patients. Okay, how we can help those patients, how we can improve the treatment for the young patient. In general, we can add something or augment the treatment we are already offering. Augmenting by increasing the duration of the treatment in the era of hormonal treatment, the extended hormonal, 7 years or 10 years, not only 5 years, especially in the high-risk population. And we can add something, either the PARP inhibitors, if the patient is BRCA mutant, ovarian suppression, of course, and the CDK4/6 inhibitors, if the patient is eligible for the Monarch A trial or the Natalie trial. But if we offered the patient all these treatments, and she will suffer a lot in form of long list of toxicity, added toxicity of the different drug modalities, psychological burden and psychological toxicity, also the financial toxicity that we can't ignore. Okay. And if we can offer this to the patient and ignoring the financial toxicity, and the patient is willing to receive all these treatments to improve her outcome, are they really adherent and compliant to this treatment? Let's review the data from the famous soft and text trial, where they showed that there is a discontinuation of the ovarian suppression among the young population, reaching 14% in the first year of the hormonal treatment. We are not talking about the 7 or the 10 years of the hormonal treatment. In the first year, almost 14% the patient discontinued the ovarian suppression or asked to stop it. And the number rise to 25% by the 4th year. We are not yet approaching the 7 year, at the 4 year. And the analysis shows that the patient who had stopped their ovarian suppression was in the below 35 cohort, most of them. And why the patient was not that encouraged to continue the ovarian suppression or the treatment? Due to the long list of the side effects, either the musculoskeletal pain, hot flushes, mood changes, and the vaginal dryness and decreased libido and sexual dysfunction. So after I had reviewed with you all this data, once I was in my clinic at the National Cancer Institute, and an idea came to me. Regularly, I see the patient of the hormonal treatment, and I ask them, tell me, what about your day or your last month? Everything is okay? Everything is okay? Are you doing well? انت كويسة؟ ماشية على العلاج كويس؟ كله تمام؟ And the patient answer, تمام، أنا كويسة. But what is how much is كويسة أو تمام؟ هل هم فعلا اليونج ايج دولت ماشيين على علاج والموست بقوا كرونيك بيشنت؟ احنا بنتكلم على بريست كانسر هيقعد 7 سنين 10 سنين بياخد علاج، يعني يتحول من كرايسيس بريست كانسر فيهم لكرونيك ديزيز. هل هم فعلا كويسين وكوبنج كواليتي وايز كواليتي اوف لايف؟ بيقولوا ان احنا تمام، بس انا صراحه كنت محتاجه اعرف هم تمام قد ايه وقد ايه coping with the treatment. So the idea came to evaluate this specific cohort of young patients with a well-structured questionnaire, which is the ERTC Quality of Life Questionnaire, BR145, which focus in the global quality of life aspect and the sexual quality of life aspect in the hormone-positive breast cancer patient. And also the data analyze the demographics factors of the patient, treatment regimen, duration of the therapy, and the function and symptomatic scale according to this questionnaire. And here is the snapshot from that questionnaire, which was translated to Arabic, and the patient read it with the help of her physician and give a score to each one of those questions, ranking from 1, 2, 3, 4. 1 is the mildest symptom or suffering till the 4, which is the maximum. Okay, we had asked about every aspect almost: the hot flushes, the mood changes, the femininity issues, and the sexual issues in details, receiving hormone treatment, her past life, and currently while she is receiving the hormonal treatment, the side effects of the vaginal dryness and the dyspareunia, also the musculoskeletal side effects, weight gain, which is of concern for the young population, the side effects related to the surgery and the upper limb lymphedema, joint dysfunction, and finally the adherence to the treatment and her willing to extend the hormonal treatment. And here is the result. Our patient median age was 41 years old, ranging between 25 to 45 years old. Most of them was stage 2 or stage 3 disease, 55%. And the primary hormonal treatments they had received was a combination with tamoxifen and ovarian suppression, almost in 55% of the cases, and 88% of them had received chemotherapy. And this diagram telling us the distribution of the different hormonal agents used in our population. And again, the majority were the combination of tamoxifen and LHRH. Tamoxifen alone almost in 30%, combination AI plus ovarian suppression almost in 8%. And the common side effect reported by our patient, which is real data from our Egyptian population, that almost 75% of the patient reported at least one side effect, which is reported here, hot flashes or bone aches. And majority had reported more than one side effect. And surprising enough that among patients taking Zoladex and tamoxifen, 80% had suffered from hot flashes and bone ache, 80%. And maybe 80% someone will argue me that they had grade 1 toxicity, which is not a big deal. But the data told us that those patients, 50% of them had reported, according to the questionnaire, more than 3. They give her symptom at a grade 1, 2, 3, 4. 50% had reported that it's more than 3. And we are talking about young patients. We are already cured from breast cancer. And what about the sexual activity? Specific to the last month, to the date of the questionnaire, 50% of the patients between 25 and 45 years old had no sexual activity at all. No, big no. And those was active only 33%. And if we was optimistic, we can add this sector to them. And almost all those patients are sexually inactive. Okay, and if we reviewed with those small sector who were sexually active for the last month, what about the sexual enjoyment or their pleasure with the process? Only 7% had reported being happy with being sexually active. Compared to before the treatment of the hormonal treatment, it was 31%. You can imagine the decline, which was very significant statistically. Additionally, 48% of the patient experienced complete lack of the desire, thanks to the ovarian suppression, and 38% of them asked for psychological support. They in need for psychological support. Okay. And this figure telling us the difference between the sexual enjoyment before and after receiving hormonal treatment. Let's focus in this pink column, which is sexual enjoyment after hormonal treatment. Not at all this big line. Compared to before the treatment, was that less, or that high? Apparently they are suffering a lot. Okay, what about they're willing to accept the extended duration of hormonal treatment with all this background or all this self-reported side effects? Almost 50% of our patients are willing to extend the hormonal treatment. And was refused by 15% only of our cases. As conclusion, this finding reveal a profound impact of hormonal treatment on both global and sexual quality of life in young breast cancer patients, the significance of decline in sexual enjoyment and desire, coupled with substantial need for psychological support, and underscores the necessity of integrated care strategies that address the comprehensive health challenges faced by those cohort of patients. This finding also suggests the need for tailored patient education and support program, focusing on management of the side effects and providing a comprehensive information on the benefits of the hormonal therapy, And if we can success to do so and the patient are willing to adhere to the treatment, this will reflect to the patient outcome. And here I can congratulate my dear professor, Dr. Amani Hilal, for our success to publish this work in the last ESMO Congress at Barcelona. Under her supervision, with Dr. Imad Shash, and with the help of my dear professor, Suzy Sami. And thanks to Dr. Reem Imad for the statistical analysis and dear friend Manor for the data entry. And thank you for your attention.
Thanks, Dr. Omnia, for your intelligent and very useful lecture. All of us, most of us, not take care of this side of patient. Thank you for remembering us that this information is very important for us and for the patient. Thank you. كومنت من دكتور حسين.
انا بشكر طبعا الستيم بروفيسورز وامنيه على المجهود الجميل ده، لان انا فعلا لازم نعترف ان احنا الكالتشر كله ما بيعترفش بالكواليتي اوف لايف. الفيزيشن البيشنت نفسه هو بيحس ان ده لاكشري ان انا اتكلم على كواليتي اوف لايف، وعيب لو انا اتكلم انا عندي كانسر وريليف طبعا. وفعلا احنا عايزين نعمل هايلايت على ده. انا عايز اقول حتى في البابليك سيكتور في البرايفت محدش بيهتم بده، ولكن فعلا it is the right for our patient. This is my comment. واشكركم جميعا. شكرا.
شكرا دكتور حسام. Thank you.
First, I would like to thank Dr. Amani for the invitation. ان شاء الله في تقدم دايما دكتور اماني، وعقبال السنين الجايه كتير ان شاء الله. Now مع بروفيسور عبد الحميد فؤاد، consultant of medical oncology بهية، lecturer of medical oncology NCI, Imaging Symposium.
Good afternoon. Thank you, chair persons. Thank you. Thank you for the organizing committee, Professor Amani. Thank you. Thank you, Amgen, for inviting me for this talk. In the coming 20 minutes, I will cover the role of denosumab in prevention of skeletal-related event in metastatic breast cancer patients. This is my disclosure. This is my agenda. We will talk briefly on the overview of bone metastasis and its consequences. The goal of treatment of patient with metastatic metastatic breast cancer to bone, the mechanism of action of the denosumab, and the evidence based on the efficacy and safety of denosumab. As we all know that bone metastasis is a common sight in almost all solid tumors, especially breast cancer and prostate cancer. As we can see, breast cancer patients have 61.4% of the patients will have bone metastasis, and followed by the prostate cancer. And these bone metastases result in clinical significant and serious consequences leading to serious skeletal-related events, especially pathological fractures and spinal cord compression. The pathological fractures may affect long bones leading to disability, or the vertebral collapse leading to loss of weight, loss of height, and rib fracture may lead to restrictive lung disease. On the other hand, spinal cord compression, if not managed within 48 hours by a decompressive surgery, may lead to disability and severe pain and poor quality of life. Usually we treat these skeletal-related events by radiation that play a major role in relieving pain, but unfortunately for a short period of time. And surgeries like bone decompressive surgeries and fixation usually is associated with high risk of perioperative mortality and poor survival for most of these patients. The skeletal-related events caused by bone metastasis represent a substantial burden for both the patient and for the healthcare systems. For the patient, usually patients complain from pain, bad physical, social, and emotional status, sleep disturbance, and this reflect on his quality of life and need hospitalization and associated with shorter survival. And on the healthcare systems, most of these patients require frequent hospital visits and hospital stays and increase the cost of treatment of most of the patients. As we can see here in this trial, that the incidence of skeletal-related events increase with time. Most in the first year, almost 40% of patients with metastatic breast cancer to bone will have skeletal-related events, about 40%. In the first 3 years incidence, it will reach 48%, and in the 5-year incidence will reach more than 50% of the patients. We have a problem that it is reflected on the healthcare system and on the patient, and it is increasing with time. Moreover, we can see here that the skeletal-related events is common and more frequent if untreated. On the left, this is the percentage of patients that develop with bone metastasis that will develop skeletal-related events. In more than 60% of breast cancer patients within the first 24 months will have skeletal-related events if not treated. And the mean number of skeletal-related events per patient per year, it's more than 3. The patient will have more than 3 times different first and subsequent skeletal-related events if untreated. And also the skeletal-related events is in the first year is more than 45% in patients with metastatic breast cancer to bone. What's our goal? We have a problem with a major burden. What's our goal? The goal of treatment trying to prevent or delay the skeletal complications or bone events not to happen. And if we have already these events, we need also to reduce the number and to delay the subsequent skeletal-related events with its complications. This will be reflected to reduce the overall skeletal morbidity, better quality of life, less costly treatments. Using the traditional anti-cancer therapies and also bone-targeted therapies, aiming to relieve pain and prolong the time to develop skeletal-related events. The denosumab is recommended by most of the guidelines, the famous guidelines, to manage the patient with metastatic breast cancer with bone metastasis and other solid tumors, and also some hematological like multiple myeloma. What is the mechanism of action of denosumab? Before going to the mechanism of action, we have to know there is a rank ligand osteoproteogene signaling pathway. This pathway is balanced by some factors. The estrogen and the bone morphogenic protein usually enhance the expression of the OPG. And on the other hand, the interleukin-1 tumor necrosis factor alpha and vitamin D parathormone related peptide help the binding of the rank ligand to the rank. The rank ligand stimulates the rank, which is receptors on the osteoclast that when activated, it stimulates and increase the number of osteoclasts, increasing the bone resorption. This is what happens if a patient have a tumor cell in his bone. The tumor cell release parathyroid-related peptide that as we said, it enhance the binding of the rank to the rank ligand on the cell surface of the osteoclast, leading to increase the number and increase the activity of the osteoclasts, and this will lead to increased bone resorption. And this increased bone resorption will lead to more progression and more release of the growth hormones from the tumor cells, ending by a vicious circuit, ending by frequent skeletal-related events with its consequences. Denosumab bind to the rank, preventing the binding of the rank to the rank ligand on the cell surface of the osteoclast, so inhibiting this vicious circuit, inhibiting the stimulation of the osteoclast and inhibit the bone destruction and preventing the skeletal-related events to happen, and if happen, to decrease the subsequent skeletal-related events. But this is the mode of action. This is the denosumab. It's a fully humanized monoclonal antibody that, as we said, bind to the rank on the cell surface of the osteoclast, preventing binding of the rank to the rank ligand on the cell surface of the osteoclast, suppressing the osteoclast, reducing its number and function, and decrease bone resorption. But this is, as I said, the theory. Did we have evidence? Did we have evidence for the efficacy and safety? Yes, we have three pivotal phase 3 randomized registration studies. These three trials, one of them include breast cancer patients only, and the patients were randomized to receive, it's blinded, denosumab plus placebo versus zoledronic acid plus placebo subcutaneous, evaluating the comparison between the efficacy and safety of denosumab and the zoledronic acid. And the primary endpoint is non-inferiority of the denosumab regarding the time to the first on-study skeletal-related events. And it has multiple secondary endpoints, including subsequent skeletal-related events and superiority of the denosumab in terms of the first on-study skeletal-related events and other safety and tolerability secondary endpoints. This is the safety endpoints and other exploratory analysis. This is the patient characteristics. It was balanced between the two arms. It includes about more than 5,000 patients, the three phase 3 trials, and about 36% of the patient in this analysis was breast cancer in both arms. This is the curve for the primary endpoint. As we can see, the time to the first on-study skeletal-related events was 19.5 months in the zoledronic acid arm versus 27.6 months in the denosumab arm, with a hazard ratio 0.83. That means that we have 17% risk reduction in time to the first on-study skeletal-related event, with improvement in, we have gained 8.2 month delay in the first on-study skeletal-related events. So the trial was positive in its primary endpoint. In another point, we can see the number of subsequent on-study skeletal-related events in the zoledronic acid arm. It was higher, 1,628 versus 1,360 in the denosumab arm, that we have 18% risk reduction because we have a hazard ratio of 0.82. Also, regarding pain control or improvement of delaying worst pain for patients, in the zoledronic arm, it was the time to moderate to severe pain among patients receiving zoledronic acid, having no or mild pain at baseline, was 4.7 months versus 6.5 months in the denosumab arm. We are talking about 2 months gain in the denosumab arm. Regarding safety, both arms of the trial have similar safety signals, apart from increase in the acute phase reaction in the first 3 days following zoledronic acid, and the hypocalcemia is much higher in the denosumab arm, and renal adverse events is higher in the zoledronic acid arm, while osteonecrosis of the jaw was almost the same in both arms. Regarding the need for dose delay or dose reduction in the zoledronic acid arm, the patients need dose delay or dose reduction, while in the denosumab arm, no patients require dose delay or dose reduction based on the renal functions. Regarding hypocalcemia, as we mentioned, it is more in the denosumab arm, but most of these patients were asymptomatic, and in the post-marketing settings, the severe hypocalcemia occurs in the first weeks of therapy only, and after that it is not significant. And the higher rate of hypocalcemia can be explained by the zoledronic acid have more potent anti-resorptive effect versus the zoledronic acid. And how can we guide our colleagues to minimize the risk for hypocalcemia? First of all, if the patient has a pre-existing hypocalcemia, should be corrected. And before treatment, you have to give supplementation with calcium and vitamin D. You have to monitoring at baseline and especially every 2 weeks if of the initial dose, and if the patient have symptoms. Also, you have to have special care to patient with high risk to develop hypocalcemia as patient with elevated kidney functions, because patient with elevated kidney functions have higher incidence to develop hypocalcemia. And also we have to educate our patients about the symptoms of hypocalcemia and to be aware about these symptoms. Also, if the patient have hypocalcemia during treatment with denosumab, extra doses of calcium supplementation may be needed. Regarding the osteonecrosis of the jaw, we found in the 3 pivotal phase 3 trials that osteonecrosis was infrequent, and the incidence was nearly similar in both arms in the first year and in the second year, with slightly higher in the denosumab arm. But among the patients having osteonecrosis of the jaw, most of the patients in the 40%, not most, 40% of the patients most of the patients have conservative treatment only, and then followed by minor interventions, and only 6% have need bone resection. On the other hand, the zoledronic acid have similar results. But among patients having osteonecrosis, 81% of them have poor oral hygiene, previous recent tooth extraction, and most of them were receiving chemotherapy. And there is regarding resolution of the osteonecrosis, about 40% of patients with receiving denosumab have resolved osteonecrosis, and the median time to resolution was 8 months. And in zoledronic acid arm, 30% only of the patient have resolving osteonecrosis with median time 8.7. After this trial, we have an extension open label phase 3 trial evaluating the safety of long-term outcome. After the primary analysis of the previous discussed trial, they ask the patient if you need to continue on denosumab or to be just under follow-up for 2 years to evaluate the long-term safety outcome. So we after either the patient was receiving zoledronic acid or denosumab, he was able to receive 2 more years of denosumab or to be kept under follow-up. They concluded that no new safety signals after a long-term treatment was with denosumab, or if the patient was switched from zoledronic acid to denosumab, and also no neutralizing anti-denosumab antibodies. That means it is still effective. As we see here, this is the incidence of adverse events in patient continued 2 more years of denosumab or switched from zoledronic acid to denosumab. They all, in the breast cancer patients, they were almost the same also in prostate cancer patients. Apart from mild increase of osteonecrosis of the jaw for patients receive extended denosumab. And they concluded that osteonecrosis of the jaw rate increased slightly if the patient received denosumab for a long period of time. But on the other hand, the skeletal-related event, if not giving the anti-resorptive bone measures, we will still have the risk to increase and over the benefit of not giving the denosumab. And this is guidance for high-risk patient receiving denosumab to avoid osteonecrosis. Before starting treatment, the patient should have a dental examination and appropriate preventive dentistry. If he has a problem, should be treated before starting denosumab. And for those patients having high risk to develop osteonecrosis, like patient receiving corticosteroids or chemotherapy, or patient with advanced malignancies or poor oral hygiene, should have an individual risk benefit assessment. What is the risk? What is the benefit? And during treatment, try to maintain good oral hygiene, routine dental check up, and also inform the patient if he develop any oral symptoms like mass or loose teeth or swelling or something like that, to contact his physician directly. And also invasive procedures in the teeth should be carefully done and not very close to time of administration of denosumab. The patient should stop, I think, for at least 3 months before doing any dental procedure. To summarize, bone metastasis is very common in solid tumors, and if untreated, it can lead to serious consequences, including serious skeletal-related events that will significantly affect the patient and will have a high risk on the patient and on the health care systems. Denosumab is recommended to prevent or delay the skeletal-related events. Denosumab is a fully humanized monoclonal antibodies that work by binding, preventing the binding of the rank to the rank ligand, inhibiting the osteoclast activity. It shows superiority to zoledronic acid in delaying or preventing the first skeletal-related events and the subsequent skeletal-related events. And also safety signals was also almost similar in the primary pivotal phase 3 trials and also in the extension open label trial, apart from mild increase of osteonecrosis of the jaw. And the denosumab try to solve the unmet needs of the patient that need bone targeted agents. It required no dose delay, no dose adjustment for patient with elevated renal functions. There is no acute phase response in the first 3 days of therapy. Also, it is convenient received by subcutaneous, not need venous access. No need for increase the workload for the healthcare system. Thank you. Thank you.
Thanks, Professor Abdelhamid, for your lecture. And في أسئلة? Question? Thank you.
شكرا.
Thank you.
We have pleasure to introduce Dr. Ahmed Magdi. Dr. Ahmed Magdi, consultant of oncology, National Cancer Institute, and he will speak about the optimum use of Zerzio with the medium and high risk regimens.
Thank you for the beautiful introduction. I would like to thank Sandoz for inviting me to be their speaker today. So today I'm going to talk about the optimum use of Zerzio with medium and high risk regimens, and why are we saying medium and high risk? We'll know as we go on. And yeah, here we go. These are my disclosures. And first of all, we have to understand what's febrile neutropenia. So febrile neutropenia is an elevated temperature of the patient in a neutropenic patient of 38 more than 1 hour, or a bump of 38.3 once in a neutropenic patient. And we all know febrile neutropenia is very risky and carries lots of mortality. Why? Because the clinical consequence of that is delaying in chemotherapy. So you will lose the chemotherapy window of your patient, and actually you might lead to dose reductions. And we all take dose reductions for granted as it's doable, and I'll show you some evidence that those reductions will affect the outcome for our patients, and definitely a complication with life-threatening conditions up to ICU admission and mortality. If you look at the febrile neutropenia in general is associated with prolonged hospitalization, and this is a cost. I know most of you will tell me that we do have the nursing and everything is a little bit cheaper than anywhere else in the world. However, the bed itself is the cost. So we do have limited beds, so we don't need the prolonged hospitalizations for our patients. Although, and of course, the hospital costs will be very high for those febrile neutropenic patients. And actually, it is associated with increased risk of death, specifically in lung cancer, and as you can see here, in breast cancer, with those with febrile neutropenia in comparison with those without febrile neutropenia. Remember when I said the dose reductions? So this is a paper published, yes, it's an old paper in 2008, but it showed that the relative dose intensity, if it's less than 90%, then we are talking about decrease in survival. So what we take for granted that by decreasing the chemotherapy dose actually could affect the outcome of my patients. And again, from a real-world data, but this time from the, it's a little bit newer, from 2010 with diffuse large B-cell non-Hodgkin's lymphoma, yes, you do get a decreased survival for those patients. And also, we do have some data that shows that when you give the filgrastim as primary prophylaxis rather than secondary prophylaxis, you decrease the, and this is a phase 3 clinical trial, by the way, so you decrease the duration of hospital admission and actually decreasing the usage of antibiotics and getting more effect and more efficacy with the antibiotic regimens you've been using. And you can see here, in comparison, you do get the usage of antibiotic 36% reduction in the incidence with the antibiotic use even, and reduction of 33% with hospitalization. With all that said, and with all this evidence present, yet until today, 1/3 of the patients will receive the GCSF prophylaxis. And for the low risk, it's okay to do that because we all know solid tumors, in general, they do tend to have a low risk of febrile neutropenia. And with the CDK4/6 inhibitors, for example, we never use the GCSF because it's a very short-living neutropenia, and the rate of febrile neutropenia is around 1% to 2%. However, most of our patients lie within the intermediate 48%, and the high, thankfully, is only 9%. So with the usage of GCSF, you do get reduced cause of all causes of mortality, and you do not decrease the chemotherapy dosage. Remember the relative dose intensity we spoke about. But then we have to divide our chemotherapy regimens into high risk and intermediate risk. And according to that, how are we assessing our patients? Is it subjective by my own speculations? Well, actually, we do have a multinational association for supportive care in cancer, as known as the MASCC, a scoring system that tells you this patient is a very high risk or an intermediate risk. And if you look here, with the hazard rate, with the chemotherapy regimens here, you can look at the breast cancer, and we all have been using the dose dense because it has affected the overall survival and response rate in our young patients. And you see that those patients are categorized as high risk. And you look here at the schedule for the breast, the lung, the colorectal, and so on, you get the division between, or the idea about the high risk and intermediate risk. Also, don't forget, it's not about only the chemotherapy regimen. It's about the patient risk factors, the age, of course, the persistent neutropenia. What about the liver function, the kidney functions? If the patient have received prior chemotherapy or radiotherapy, which could affect the bone marrow reserve. What about the performance status? We need to have look at the performance status. So you have to put the disease burden, the chemotherapy regimen you're using, and the patient factor put in mind. Primary prophylaxis, you are anticipating the neutropenia that will happen, so you should start upfront and abruptly start with the GCSF prophylaxis. And this has been, I believe, widely used in the dose-dense regimens automatically. What about secondary prophylaxis? Is you give the patient the chemotherapy at first, he experiences neutropenia, so we start with the second cycle prophylaxis with secondary prophylaxis with the GCSF. What is GCSF? Colony stimulating factor. So it's an exogenous granulocyte colony stimulating factor. Naturally up there, you get the mitotic phase for the myeloblasts leading to the neutrophils at the end. As you can see, it gets from 3 to 9 days with only 5 to 7 days of post-mitotic phase, which means that you do have this automatically will happen to our body, but it will take a longer time. Can we minimize this time? With the GCSF, you minimize that to 1 day. So I'm saving my patient, and I've showed you before, but keep in mind, please, those 1-day neutrophils are actually immature. So we don't give the GCSF as only one injection, because this 1 day, these are absolutely immature, and when you stop the GCSF, if you do the CBC, you will find your patient neutropenic back again at day 2. So it's a minimum of 3 days of GCSF support. This slide just shows you, it's a busy slide, but just to show you that the GCSF has been implemented since 2010 with a special implementation during the COVID era, as we all remember that they allowed us to give the oral chemotherapies and support with GCSF, avoiding the neutropenia to avoid the infection of COVID-19. Your tech-based febrile neutropenia risk assessment have included already the European guidelines with the GCSF prophylaxis. Suboptimal use have been reported actually worldwide. I'm not pointing out that only or even in Egypt only. It's worldwide. The usage of GCSF has been or have been already underlooked previously, leading to more hospital admission, treatment delays and cancellation, dose reductions, as we mentioned before, and even mortality. So what are the proper guidelines for using the filgrastim or the GCSF? Administered daily for up to 2 weeks, or if the absolute neutrophilic count reaches 10,000, please stop. Because sometimes we're faced with patients, you're giving them the GCSF and you don't see an improvement. You do not stop, you keep continuing. Or if you're using it at a shorter course, you will have an increased risk of febrile neutropenia, and then with the consequences that I've said before. However, sometimes we're facing a patient with febrile neutropenia being admitted to the hospital. Should we give them the filgrastim? Actually, if you look at the guidelines, there are specific situations to give them the GCSF rather than automatically giving to all your febrile neutropenia patients if they come with febrile neutropenia. And this is adopted from the NCCN guidelines. So if you do have an age more than 65, a sepsis syndrome, septic shock, and neutropenia expected to be lasting more than 10 days, and this is mainly with the hematological malignancies, absolute neutrophilic count less than 100, which is the profound neutropenia, and this is very dangerous. Invasive fungal infection, and this is again maybe we see it more with malignant hematology, hospitalization at the time of fever, and a prior episode of febrile neutropenia. So if you do have your patient with a previous history of febrile neutropenia and comes to the emergency department with febrile neutropenia, automatically start the GCSF. So remember, the title of my talk was the Zarzio. So what is Zarzio? So Zarzio is a biosimilar to the GCSF. What are biosimilars? So biosimilars, they are a complex molecule that resembles the originator molecule, but only what is known to us is the amino acid sequences according to the bylaws that the company should receive, the originator company should release the amino acid sequence and the basic structural components. But we don't know the cell line, the growth media, the methods of cell expansion, how to culture those cells, the bioreactor itself, how to package, how to save, how to transport. All these are very, very tedious processes. And this is just to give you an idea about the process of doing the biosimilar. So biosimilar is not a new concept. Biosimilar has been there since 2005. Europeans are very well known to have been using the biosimilars. And actually, if you look at the data, this has saved them, I think, as I can remember, 14 billion or 140 billion euros, I'm sorry, all through with the usage of the biosimilar. So biosimilars actually, with saving the money, you'll get more access to maybe newer drugs, maybe expand your cohorts for more availability of the drugs, okay? And it allows the penetrance to the patients and actually cost saving. And intermediate risk patients, again, with all what I'm not going to repeat myself, but saving the money, saving the lives, and hospitalization. And actually keeping in mind, biosimilar are similar to the originator drug. It's not better and it's not worse. So it's, let's say it's equal to the originator drug. What do we do from the cost saving? Definitely you get an effective targeted therapy usage. Maybe you can expand the targeted therapy usage. More patients will have access. they free up the budget. Maybe you can include more drugs in the later on, and maybe switch the budget from the oncology. Maybe we look at another subspecialty, and this will be good for our patients. The optimal use, don't forget the short acting is you can use it and control how long you give the injections. It's easy to be administered at home even as a subcutaneous injection, and you can monitor your patient more frequently, as you can bring him every week to the clinic to assess him clinically and follow up your patients. The mechanism of actions, it binds to the granulocyte colony stimulating factor receptors in let's say stimulating the production and release of the neutrophils that I showed you, and it actually take 1 day, but please don't forget this 1 day release of neutrophils are immature neutrophils. And this is a phase 3 randomized study comparing the originator drug with the biosimilar, and their conclusion was they were similar with no clinically meaningful difference. Don't forget, I'm not proving that the biosimilar is better or the originator is better. They have to be bioequivalent. And it's an important alternative with increase in access to the treatment. So to conclude my talk, febrile neutropenia is very dangerous in intermediate and high risk. You have to put in mind, assess your patients upfront with the chemotherapy regimens used, the patient factor themselves, and the previous history of febrile neutropenia. Please prophylaxis and always anticipate febrile neutropenia, and primary prophylaxis is way better than secondary prophylaxis rather than waiting for the problem to happen and start managing. Biosimilars are not generics. They are equivalent to the originator, and they are safe, equivalent, and effective as the originator, and it would definitely impact our budget. And thank you so much for listening.
Thank you, Dr. Ahmed Magdi. And any questions?
Thank you, everyone. Now you can close the session.
I have one question. Thanks, Dr. Ahmed. Excellent lecture as usual. I have one question for you, and I think Dr. Hussam will help answering this question. Do you find the role for growth factors in prevention of febrile neutropenia in patients with acute leukemia receiving induction therapy?
No.
انا خلي بالك هيحصل خلاف بينك وبين الدكتور حسام.
لا هنتخانق انا هو. بس so GCSF actually in acute leukemias will increase the blood cells. So there are data that says that with the presence of blood cells when you give GCSF it increases the blood cells. However انا عارف ان صديقي هيتخانق معايا.
انتوا اصدقاء وانا مش عاجبني.
ما انا هقول اهو ثواني هقول. It has been, there were ongoing trial in acute leukemias that if you give the GCSF with increase of blood cells and you give the induction treatment, would this be translated into a better outcome? Actually, these were negative trials. ما اعرفش دكتور حسام ودكتور هبه.
لا حضرتك الاول.
لا يا فندم.
طيب هو انا طبعا هنقسمها الاول لايه ال وايه ال. ايه ال مفيش عليها اي خلاف خالص، بالعكس هي حسنت السي ار ريت عشان الدوز دنسيتي. حسنت السي ار ريت. في الاي ام ال طبعا هي كونتروفيرشن. الموضوع الانكريز باسل ده ثيوريتيكال كونسيرن، ولكن في ستادز كتيره اتعملت، في حاجات ويز وفي حاجات اجينست. يعني مفيش حاجه قالت ان هي زودت او قللت السي ار ريت فرانك. في ميتا اناليسيس اتعملت عليها كتير، ولكن مفيش حاجه قالت انها قللت السي ار ريت. ولكن في يعني براكتيكالي سبيكينج احنا بنتكلم على اللايف ثريتنينج انفكشن فري هاند. لايف ثريتنينج انفكشن فري هاند تو جيف. وانا بتكلم على براكتس انا عملته بشكل كبير. لا في فعلا فاليو للريدكشن بتاع الريت اوف مورتاليتي، سبيشالي ان احنا في مصر عندنا مشكله كبيره في الانفكشن كنترول، والكالتشر ار نوت كلين ات اول، وده يخلي الرول بتاع GCSF في مصر اعلى من الداتا العالميه الموجوده بشكل كبير جدا.
especially mucormycosis actually is rising. احنا بدنا نشوف mucormycosis كتير واحنا ما كناش بنشوفها.
احنا بنشوف كل حاجه. احنا يعني جايبين عندنا في مركز اورام طنطا اوتوميتد كلتشر، فبدات بشوف عجب العجاب يعني بصراحه. ده كومنت.
لو ممكن اقول حاجه، هو الحقيقه GSF we never encountered any leukemia يعني post the GSF، ولكن ممكن leukemia arises as direct as a chemotherapy induced leukemia، وده بيحصل اذا حصل كو انسيدنس مع جي اس اف مثلا فنقول يا ده جي اس اف عمل لوكيميا. No, it is not the GSF. It is chemotherapy induced acute leukemia وده يعني شفناه الحقيقه وتابعناه.
هو ما فيش وقت، بس الحته دي بالنسبه لي فيري هوت. الايرا او الثينكينج ان we can induce some increase in the plast cell while we are treating an episode of febrile neutropenia in any acute leukemia is completely not practical and not proved.
It's a gray zone, yes.
لا خلاص ما فيش gray zone. It is not affected at all. If your patient have deep-seated fungal infection, if he have prolonged deepening neutropenia, you are saving his life. هقول قصة بسيطة جدا تعبر عن موقفي، عشان كده أنا اتخضيت. يعني 1991 بمر انفكشس ديزيز، النائب بتاعي الأستاذ الدكتور حاليا محمد عبد المعطي، وهو بيرزس يقول لي يا دكتورة هبة ايدك فرطة شوية في الجروس فاكتور. بقول له عشان العيان لو ما لحقناهوش في ال3 ايام، لا اما هنغير في ال7 ايام وهياخد 7-8 انتي فايرال وانتي فانجل، لا اما كلهم شباب صغير وديب سيتد انفكشن ومونوليزيس وريكتال انفكشن وكذا. فاحتكمنا للراجل اللي اكبر من، هو قدي سنا بس اكتر مني خبره، حسام كامل. دكتور حسام كامل كان مسؤول عن اوض الزرع، وانا بمر بمنتهى يعني بس only infectious control في اوض الزرع. فجبنا الدكتور حسام قال never this suit is never practical وما تخافوش. ومن ساعتها في يعني زي جوك بيني وبين محمد عبد المعطي ان انا ما تخافش يا محمد وكسبتك، يعني ماشي رايي، يعني ماشي رايي. فمعلش يا جماعه، ده حتى انا معلش انا اسفه جدا، انا كنت في امريكا انفكشس ديزيز، الفيلو اللي عملتها كنت مسؤوله على الانفكشن كنترول او انفكشس ديزيز ان سيفيرلي نيتروبينيك بيشنت ايفن زو استقبلنا حاجات في الان اي اتش ايدز في هذا الايرا 1900 وحاجه و90. فستيل نو they are proliferate the stem cell which is normal they cannot، لان التانية عليها ميوتيشن وعليها حاجات جروس فاكتور مش الزرزرو ولا النيبوجين اللي هيحركوها، لان كانت البريست كانسر بيشنت جالها لوكيميا بقى.
بس
فاهم قصدي حضرتك؟
فاهم حضرتك طبعا. بس هو بس يمكن انا ما وضحت غلط، انا قصدي not from the start. انا حطيت ال NCCN guidelines كاتبه if the patient is in septic shock or a history of febrile neutropenia you just use it على طول. طبعا مكتوبه ال NCCN guidelines. لا بس up front I mean كان زمان في داتا كان was thinking of giving it up front with the induction treatment
انتهت في 1991.
دكتور عبد الحميد.
هو في سؤال على موضوع برضه ثيوريتيكال كونسيرن تاني على الثرومبوسايتوبينيا، يعني برضه كان في ثيوريتيكال كونسيرن اولد على الحته دي كمان.
لا مش موجوده. والريت بتاعها if you look at the even if you look اسمه lexicom for example you will find it's rare less than 1% اصلا. فحته الميث بتاعت لما يبقى العيان بليتلتس واطيه اوعى تديله GCSF this is absolutely wrong.
Yes.
Absolutely wrong. Sorry? لو the patient in septic shock is a red alert that we should bypass anything. We have to save his life. بس حتى في الثرومبوسايتوبينيا it is not as effective as هي كانت myth قديمة قوي.
Yes. دكتور حسام ودكتور احمد طبعا استاذتي دكتوره هبه في الحته بتاعت الاكيوت لوكيميز والجي سي اس اف، لو العيان في النادير اللي هو ما فيش ما فيش ستام سيلز ممسوح، هل هتفرق ولا عشان نديها لازم يبقى في ريكفرنج بون مارو؟ يعني قصدي اقول تفرق في التايمنج، لان لو هي ان في السيفير نادير هل ليها قيمه حتى لو العيان في سبتك شوك ولا مش اكني بحرق الجي سي اس اف ده على الفاضي؟
ديفرنشيتد سيل انا معاك اهو، واحد عملت له كاونت لقيته 0.000 ما فيش. طيب الستيم سيل بتاعته ذا بومر موجوده ولا لا؟ بس هي بتشتغل عليه، يبقى ينفع للبريفرال.
احنا ما عرفت يعني دكتور هبه، احنا ما كان في اسئله في during السيشن، واحنا كان عندي سؤال انا شخصيا بمناسبه الميتابلاستيك. خلاص خلصنا اللوكيميا. ميتابلاستيك برضه. فميتابلاستيك بريست كانسر one of سيشن اللي اتقالت النهارده. انا سؤال شخصي لحضرتك. لا سؤال يعني كومنت على المحاضره. الناس اللي جايين بوردر لاين ريسكتبل ميتابلاستيك بالبيهيفير اللي حضرتك عارفاه، وهو طبعا طلع تريبل نيجاتيف، candidate for neoadjuvant chemotherapy ولا go for surgery upfront؟
بص، هو الميتابلاستيك is very resistant tumor and usually it will not yield easily with chemotherapy. بيعتمد على الستيج اوف ذا ديزيز اند بريست تيومر ريشيو، لان احنا بنشوف الحالات دي جدا. يعني انا شخصيا بروح متقمصه يا سيدي اعمل لها عمليه وخلصنا. معايا جراحين ومعايا جراحين شاطرين جدا. هو مش بيقدر لو كانت inoperable، لكن لو كانت operable وتريبل نيجاتيف we go for upfront surgery. دي من الاكسبشن اللي you can go for upfront surgery وديديكيت او تركب اللي قالته الدكتوره اماني. ما احنا كده ولا كده هنديها كيموثيرابي while she haven't nothing. بس الليميتيشن هنا لو الميتابلاستيك presented with very aggressive form and skin infiltration and lymph node مضطر انك تجرب لكن افضل الجراحه.
So finally, we thanks for all brilliant speakers and our chairman and also our professor with us. Thank you.